That's fine. Bye.
A very good afternoon to one and all, and good morning to Professor Gunnar. We at the Madras Medical Mission are delighted to be hosting the launch of the Hospital Infection Society of India Chennai chapter and the second microbiologist Chennai Microbiologists meet. The occasion is graced by many dignitaries whom I would like to warmly welcome. Please welcome Dr. T.S. Jain, Dr. Raman Sardana, Dr. Subhash Todi, Dr. Uma Shekhar, Dr. Dilip Matai, Professor Gunnar Kalmata, Dr. Suresh Kumar, Dr. Vidya Krishnan, Dr. Tyagarajan Ravinder, Dr. Sri Vidya Subramaniam, Dr. Subha, Dr. Kripa, Mr. Sushil Purohit, and the PIMS team, all our students and our staff here, and to all the staff who have, all the microbiologists who have logged in online. A very warm welcome to you. We are set to have a feast of scientific talks. So without further ado, let us start the day's proceedings. I request Father Joe Thomas, chaplain, to kindly lead us in prayer. I request you all to kindly rise.
Let's look in the Lord for prayer. Gracious Heavenly Father, we thank Thee for giving an opportunity to gather together. Oh God, You are the protector, sustainer, and redeemer of this world. You are the one who providing everything that is needed to this universe. Without You, we can't do anything in this world, oh God. We thank Thee for all the blessings You have been showering on us. You have been leading us from all this way long. God, You are the divine light. You are the source of all the wisdom and knowledge. Kindle and ignite our mind and soul with Your divine wisdom and knowledge. Make our paths right and the way straight. We pray for this newly launching Hospital Infection Society, India, Chennai. We thank Thee initially for making this possible. Oh God, bless the Hospital Infection Society, India, and all other associated chapters. In the midst of this overwhelming infections day by day, help the Infection Society of India to focus more and function thoroughly. Help them to keep the hospital infection free so that the patient would be helpful and be beneficial. Help the society to do good things to the society and to the humanity. Oh God, we pray for this gathering. Bless all the medical fraternity and the doctors. Enrich them with Your divine knowledge. They are doing great things to the society. We pray for our dignified guests, our doctors, the speakers, and all those who are participating and out through online. Make this function a blessed one. Make the discussion that about to happen a blessed one, and make that all for the beneficial for me. Bless everyone who worked hard to make all these things possible. As You ascribe glory to You and Your only begotten Holy Spirit, now and always, forever and ever. Amen. Please be seated.
Thank you, Father. I would now like to call upon the dignitaries to please take their seats on the dais. I request the volunteers to kindly escort Dr. T.S. Jain, Dr. Raman Sardana, Dr. Uma Shekhar, Dr. Dilip Matai, Dr. Raju George, our CEO. Please take their seats on the dais. Dr. Tori, really sorry, we were looking at you for the talk, and so there was a small miscommunication. I'm sorry on that. Today is a very special day as many of my mentors are here. Dr. Raju George, Dr. Dilip Matai, Dr. Uma Shekhar, Dr. Guna Kalmekar. I have learned so much from them. Leadership and true inclusiveness and vision. This best describes our CEO, Dr. Raju George to you. Being a cardiac surgeon and an epidemiologist by training, and a CEO and an administrator, who is the director for strategic planning, National Health Services UK, he is acutely aware of the need for infection control and microbiology in a hospital. I request you to kindly welcome the dignitaries and the august gathering.
Thank you, Dr. Anisha. Today, I'm really proud, and I'm sure many of you will be envious of me because I get the honor to welcome giants in the field of microbiology, respected dignitaries on the dais and off the dais, and around 170 participants online who are joining us. And as far countries as far as Africa, there's a team joining us from Chad and obviously from Sweden. A very good afternoon to you all. And as I said, I'm really thrilled to be welcoming you to the launch of the Hospital Infection Society of India chapter and the second microbiologist meet. Now, as the CEO of this hospital, I am very, very conscious of the fact that hospital-acquired infections play a great role in the overall outcome of the patient. I'm proud to be the CEO of one of the top hospitals in India, for that matter in the world. Every Wednesday, we transmit images around the world. We are one of the 2 hospitals in India that do this. We transmit images around the world of non-interventional cardiology procedures, valve replacements, difficult valve replacements, and so on. And we have some of the best cardiologists, both in India and the world. All of their work would have come to naught if people like yourself, the microbiologists, were not taking an active part. Infection control is one of the most important things. Post-cardiac infection, surgical site infections. I know, thanks to Dr. Anusha, we have the lowest post-surgery infection rates. We are below the line in infection control rates. Always feel, as a CEO, wherever I've worked, there is always room for improvement. And so I'm really thrilled to hear words from all the stalwarts in microbiology. And at this point, I would like to welcome the Hospital Infection Society of India President, Dr. T.S. Jain, a renowned pediatrician from the All India Institute of Medical Sciences. Now he's working at the Max Super Specialty Hospital in New Delhi. Thank you very much for being here. Dr. Raman Sardana, Honorary Secretary of the Hospital Infection Society of India. Now, when you talk about hospital infection, you will never come across an article without his name. He's that famous across India. We are really delighted to welcome you. Dr. Uma Shekhar, Vice Chancellor of the Sri Ramachandra Medical College and Hospital. Being a microbiologist and infection preventionist herself, she knows exactly what I'm facing as a CEO. You're most welcome. I would like to welcome an old friend. I say old because we've known each other just for a year, I think. Dr. Dilip Matai. Quite often, he tells me off for several things, and I listen to him. Thank you very much for coming, Dr. Dilip Matai. And what I would like to do is to also welcome Professor Guna Kalmeter. I hope you can hear me, Dr. Kalmeter. I know you are 3.5 hours behind, and I'm sure you are waiting to have your lunch. But please bear with us and join us. Thank you very much for joining with us. In addition, I'd like to welcome Dr. Subhash Todi, Director, Clinical Care, AMRI Calcutta. Dr. Sri Vidya Subramaniam, Consultant Microbiologist and Infection Control Officer at Apollo OMR. Dr. Kirupa, Lab Director, Prashant Hospitals, Chennai. Dr. Vidya Krishnan, Senior Consultant, Pediatric Infectious Diseases, Apollo Hospitals. Dr. Tyagarajan Ravinder, Head of the Department of Microbiology, Pilpok Medical College. Dr. Sapa S., Consultant Microbiologist, Dr. Rela Hospital. And our very own, oh, he's there. Oh, yes. Dr. Suresh Kumar, Senior Consultant in Infectious Diseases, Triple M and Apollo Hospitals. And I also would like to welcome Dr. Arun Kumar from GD Diagnostics. Thank you all for coming. I'm really, really thrilled to hear the discourse and the discussion. Although you may not see me here, I'll be listening to the discourse from my office because I've got lots of papers to sign. Unfortunately, money to be paid out. So I won't be here. A warm welcome to everybody and a very good session indeed. Thank you.
Thank you for your warm words of welcome, sir. Lighting of the lamp is a ritual practiced in various cultures, but the meaning remains the same. Darkness cannot drive out darkness. Only light can do that, said Martin Luther King. Asatoma Sadgamaya, Tamasoma Jyotirgamaya, Mrityurma Amritam Gamaya is written in the Upanishads, meaning leading us from unreal to real, from darkness to light, and from death to immortality. To symbolize our journey to light, I request the dignitaries to light the lamp. So what is the Hospital Infection Society of India? What has been its journey so far? Many of us don't have much of an inkling of that. I now call upon the President of Hospital Infection Society of India, Dr. T.S. Jain, to give us a little bit of an idea on what the process has been for them so far, followed by Dr. Raman Sardana, who will also be giving us an idea on the same. Dr. T.S. Jain has been already introduced by our CEO, and you can see a whole lot of, a profile on whole lot of things that need to be done for the inaugural session. We will be introducing him as we go.
Thank you. Thank you, organizers, for inviting me to this excellent function and such an important function. That is the launch of the Chennai chapter of Hospital Infection Society India. First of all, I must congratulate the Chennai chapter people also for having worked so hard to bring up this chapter. Dr. Raju George, the CEO of the Madras Medical College Mission, Dr. Uma Shekhar, Vice Chancellor, Professor Deep Mathai, the Chief Mentor, Dr. Subha, Consultant Microbiologist, and my friend, Dr. Sardana and Dr. Tony on the stage. I also like to welcome all for this, the session where we are going to launch the Hospital Infection Society Chennai chapter. I must sort of appreciate and put on record my appreciation about the people who have worked day and night to bring up this chapter. First of all, the president of the Chennai chapter, Dr. Uma Shekhar, Vice President, Dr. Tyagarajan Ravindra, Secretary, Dr. Anusha Rohit, Joint Secretaries, Dr. V.R. Yamuna Devi and Dr. S. Subha, Treasurer, Dr. S. Krupa, and the executive members, Dr. B. Aarti, Dr. Vidya Devarajan, Dr. Vidya Krishna, Dr. S. Nandini, Ms. Samudiswari, Ms. Kogila J, and Mr. Sarat Babu.
Let's give them a big hand, please.
And a whole lot of people who they are representing as the executive of the Chennai chapter. So I must put on record my appreciation and thanks for bringing up this chapter and joining their hands in advancing the concept of preventing the hospital infection. That is the healthcare. Nowadays we do call it the healthcare associated infections. The Hisi was established sometimes about 30 years back. 30 years back, and since then it has reached this. The antimicrobial resistance, the hospital-acquired infections, and all, they have been recognized from the days that the healthcare has been associated and all, And as far as the introduction to the Hospital Infection Society India is concerned, I would request Dr. Raman Sardana to please present the details about the Hospital Infection Society India and and the objectives of the Hospital Infection Society India. Thank you.
We have it on the screen. Oh, okay. So congratulations, everyone. And Sir has already lauded the efforts of all of you who have been very instrumental. I remember my, about a decade and a half back when we talked to Dr. Uma Sekar, and she was, very enthusiastic about it established. But at the same time, she waited all along for Dr. Anusha and Dr. Yamuna Devi and Dr. Subha and Dr. Karupa and everyone else of you to come along and then give it a culmination today. So thanks a lot, ma'am, for your leadership. And it is actually a dream come true. We went ahead with Vellore chapter, and during COVID it took a hit, but then I think I've requested Dr. Hema Paul to rekindle that chapter. So you will have two, in fact, for that matter. So can I do it or? Okay, perfect. So as far as HISI is concerned, it's been a journey of passion. It's a journey of vision. It came out of passion, in fact. Passion for everyone who was involved at that time, including Sir Dr. T.S. Jain and the greats in, you can look at internal medicine people from Mumbai and, nephrologists from Mumbai, neurosurgeons from Delhi, cardiothoracic vascular surgeons of repute, basically Indian genre of those people who actually thought about at that time that none of the persons should actually die of hospital or healthcare. Usame, people used to call them nosocomial infections and then healthcare associated infections. They should not die. At least whatever is preventable should be prevented. That was the passion behind their work. So it's a passion, it's a vision, it's of planning. What exactly we want out of India, how we want the healthcare institutions to come up, and of dedication, of tapas, of hard work, and of teamwork, immense teamwork, in fact, for that matter, of righteousness and ethics. We have never bowed down to any pressures from any industry or from anywhere else for that matter, of ethos and of discipline, obviously to bring it up to a level as we'll go down the journey, of diligence and of faith. So people have put their faith and we have delivered. So that is something which we all adhere to very, very, very strictly. So it's an academic organization. You name the people who are in medical fraternities, the different specialities, and they are there, in fact. So talk about anybody else and they form a group in our, they form HISI constituents, whether it is pediatrics or anesthesia or general surgery or CTVS, neurosurgery or GI surgery, nephrology. So I remember Dr. Brahma Prakash and Dr. Mani, who's a cardiothoracic vascular surgeon. Both of them were very enthusiastic. At that time, we lost Dr. Brahma Prakash a few years back, though. So orthopedics, gynae-ops, lab medicine, emergency medicine, opthal, ENT, name the specialty and it's there, in fact. Pharmacologists, and obviously nothing, and clinical psychologists, and nothing can go, if we don't have nursing involved. They are the backbone. They remain the backbone. They are the front warriors. They are everything one can. The whole health system depends upon them, whether we acknowledge them or not. But especially coming from operation theaters or critical care and infection control or nursing leadership. So they are well represented now. Yeah. So we also involve CSSG managers, hospital administrators and medical leadership, healthcare quality system post, public and private sector both are represented. Some people say it is only private sector, some people say it is only public sector. No, we are both we have combined this to include everything, so that it is a representative society. And anyone who's the list belonging to standalone clinics to tertiary or quaternary care medicine or healthcare is involved. So whether it is people who are just have manning an OPD, a general physician, or single specialty units, or like a dialysis units or a ophthal unit, or whatever way it is, to primary nursing homes or primary care centers, and to secondary and tertiary quaternary care. Okay, so that is how it's a registered society. Way back, that was the vision, that it should be registered, and it is with the Registrar of Societies at Delhi, and conforms to Section 12A of income tax, so it becomes a charitable organization as for income tax purposes. Our aims have been very clear. Slight change in name, but otherwise the aims have been very clear: to increase the preventable part of healthcare associated infection. Some infection is bound to occur. If somebody says that there is a zero infection in my unit, I think either the things have not been measured properly or they are not telling the truth. Do you agree with me, people who are there? Yes. As long as there is healthcare, infections are going to be integral, because it's a world of microbes. Okay, but the key word is preventable. Decrease the preventable part of healthcare associated infections to minimum, including its dynamics with community, general community. So anything arising from community can become a problem for healthcare institutions. That is what was meant with that. To decrease the rate of emergence of antimicrobial resistant organisms in health. So we can just decrease this. Nobody can eliminate multi-drug resistant organisms. Nobody can. Nobody. It is a natural phenomenon. It will keep on occurring. So, which is now called as the AMS program by various names. So that is how it works. Now, as far as activities are concerned, it encompasses IPC and AMS, and it delivers to various forums. It has been an advisory. I'm just going to detail of that. Academic and educational activities, awareness, orientation, training programs, research activity, contributing towards national standards, publications, brings out its own publications. It also gives resources wherever they are required by various sister concerns or organizations. And we also come out with opinions and rational communications. So that is something where we find that something is going astray and it is not in the right direction, or industry is superimposing or something. Yes, we do give our opinion, and sometimes very harsh. Collaborative mechanisms are a way with us, and public awareness programs. We have started involving more and more of public into our programs. So we have got forums, as I said, whole list of forums. You can go on the website and see it. And there are various people who are there to lead the various advisors and supporters to those forum. So almost everything is covered by the various forum. And in an advisory role, we have contributed to National Safety Framework and Program 2018-5, still contributing to it. Then contributions to National Action Plan on AMR Containment 1.0, it was from 2017 to 2022. And again, we were called back to contribute in the NAP or National Plan 2.0 last year, 2022-27, in both the core working group and the advisory. So what I mean was the strength is depicted very well. Contribution to national treatment guidelines, and then the outcome, measuring the outcomes, contributing to national infection prevention and guidance and outcome, and contributions to various state programs like the SAP in Delhi or Maharashtra government AMSP program by Hisi Mumbai chapter or Mumbai forum, as we call it. So this is what I was telling you about NAP 2.0. So we were part of that. We were called on, and then we submitted whatever we have done on AMSP, what is our vision on AMSP, and what is our activity that we are going to do AMSP. And again, in 6 months' time, we were called upon where we stood with our activities and things. So we also demanded that everything should boil down to something like a 3 or 4 pager, very simplified thing. This is what the action has to be done. This is what the action has to be done. That's it. No more those big manuals which nobody reads. I'm very sorry if somebody does, but they are not read actually. So they're just referred to once in a while. But we wanted something which was 4-pager, 1, 2, 3, 4, 5, 1, 2, 3, 4, 5, 1, 2, 3, 4, 5. This has to be done. That's it. And everyone to follow that. So this is just something which just thought that evidence-based. So we do address queries and opinions coming from various members and through various forums. And this is one of the things which somebody asked about hydrogen peroxide disinfection for fogging or mist. And we had, a committee go into the things, details, and submitted the report to the head of disinfection and sterilization forum. And then it was accepted and sent. So it's just an example for all of you. So this is how we keep on working. We do indulge in indigenous research projects, and they are ongoing phenomena. They're ongoing. It is nothing which is like healthcare worker safety. So we did some program with Aligarh chapter and got through with the healthcare workers. They were all nobody there was vaccinated for hepatitis B. So we thought that this is a time when we can do that. So we took up that massive program with Jawaharlal Nehru Medical College, Aligarh, and it was a great success. So similarly, surgical prophylaxis and the whole list is there. So website will hold you more into all these things. With national standards, we work with Bureau of Indian Standards on infection prevention and control and biomedical waste. And it's, almost like a monthly meeting or month and a half. So 4 to 6 weeks, we have a meeting. We decide upon the standards, what to do, what not to do, what to have it from the West or modify it from the West or set it anew, afresh also. So those type of things. On publication, we have our own journal, which was started way back in 2013, published by Walter Kluwer, and it's called as a Journal of Patient Safety and Infection Control. And we contribute to national guidelines, as I've already talked to you. We do contribute to book chapters with various organizations, and also, on our own too. Newsletters, guidelines dedicated to antimicrobial resistant disinfection sterilization have come out from the different chapters, in fact. And there are awareness articles in press and print media for fraternity and for general public. And we do voice our strong, uninhibited, but rational statements in the press. Well, we were very, very vocal that Government of India had recognized us at that time when the Lancet NDM one article came over. So we were very vocal at that time that what are they actually targeting. So you will find them in the, and besides that also, whenever there has been a need, whether it is on antimicrobial stewardship program or on IPC, general public. So we always come out into the press, various chapters keep on contributing. So this is how it is. So volume 12 issue is in press now. Oh, this is a time to show gratitude to Dr. Geeta Mehta, who's been handling this very well. Almost though she has a lot of army of editors, but to her credit, she has done wonderful job handling almost like a one-person army. So we do welcome publication of original research. We also want all of you to further the journal grows from your side. So we have booklets on clean sterilization disinfection and the sterilization and disinfection standards book, which is undergoing revision. The first one is undergoing second edition. So that is something which is, we had some book chapters from HISI affiliation in COVID-19. And so 2 of the chapters, infection prevention and control in healthcare facility in the coronavirus disease. Way back, it came out in early late 2020, early 21. So then this is just to tell you that all this thing is in Google. You can go for Google search and have a look at it. Media creating awareness and localization. As I said, you can see the statement of Dr. Jain, our president. India is emerging as a hub for providing quality medical care at an affordable cost. It appears the study is economically motivated to prevent people from indulging in medical tourism in this region, besides promoting the antibiotic. That is what came out in August 2010, way back, about a decade back. Okay. So Aligarh chapter has been very very quick and very active in spreading good news on minimizing antimicrobial resistance, self-medications, prevention of infections and such like things. Same way Kolkata chapter. So throughout, idea is we do organize something like walkathon or any such activity, public awareness lectures, public awareness meetups, sloganeering, such like things are a part of our DNA with us. Collaborative programs with ISCCM and service we have been carrying out for decades, in fact. So ISCCM is P workshops and sessions in national and regional conferences. And we also have conferences with outside associations, outside it, that is international associations, and with IMA and with NABH. That's what we have recently started up. So like this was on NABL strength, HISI meeting on NABL strengthening. So whatever HISI can do. So it's a page, it's a 2.5 pager. So it talks about that. So just to let you know that it is all evidenced. From AMSP, teaching, training, awareness programs, we have got A to M modules on different aspects of antimicrobial stewardship. They are well entrenched, made by experts, reviewed by experts, different set of experts, and reviewed continuously. So Dr. Todi has been associated quite closely with this, and Dr. Mandal and many stalwarts who have been from outside HISI also were engaged in this. So you name whatever it is, and we are into it. In fact, we have a whole module on AMSP and what is the nursing role in it. So that's something which we de-escalation modules, diagnostic stewardship, whatever you can think about, we have, and we keep on modifying it. So we do have webinar activity during. We were not sitting quiet in the COVID era. So a lot of webinars came over, and so there were 8 national and international webinars in almost like a year and a half. And we're thankful to the experts throughout India who came up. And so we also have postgraduate orientation and teaching and training programs. And we do collaborate with National Board and NMC and the Nursing Council, Indian Nursing Council. So that is what we have asked them to incorporate or give us something where we can indulge in teaching and training at a mass level. So these are some of the things which I don't know whether you can read Hindi or not, but English, they're there. So one of the things, slogan which caught up very well is the one which is in Hindi. So it says, "Kanjusi kar, zabt kar, tauba kar, antibiotics pe tera ye khayal acha hai." So it's something which is such slogans which became very popular. Then collaborative congresses with institutions who are not HISI but still want a role to be there. So this is how it, I just gave an example to. So we hold Hisi Cons, the biannual Congress earlier. Now it is held every year. So last one was 2021. Next is due in December 2022. We'll let you know about as soon as the date is analyzed. So these are other associations with which we have collaborated. September 2023, Then in Assam, in Microcon Madhya Pradesh, and multiple review CMEs with IMA in various cities. And requesting ISCCM, IAP, this is what we have put in a request for workshop and sessions. So, so I'll just go through very quickly. You have to hold meetings. Some of them hold meetings. They have guidelines. They come out with guidelines and manuals, whatever way it is. And they hold healthcare workers camps also, BMW weeks. I mean, you can name the thing that they are indulging in, and they do it very fervently. So Delhi NCR, same way. Lucknow, Ludhiana. So community awareness talks, World Antimicrobial Awareness Week is almost like for every one of us to celebrate upon or come out with. Guwahati. And this is where we welcome you, the newborn, for us, but a very strong newborn as what has been depicted up till now in past few days that I had interaction. So gratitude to Professor Umasekar and Dr. Yamuna and Dr. Subha and Dr. Anusha who actually rekindled the whole fire. So thanks, Dr. Tyagarajan Ravinder, Dr. Kirupa, for being here as form pillars. A lot of expectations, and we look forward to next chapters in offering our Jammu Amritsar Indore. Simla probably would be in by another 3 months or so that they promised. Dehradun and Srinagar also are slated to open. We do have a best chapter award. So it's a well entrenched and aligned thing. So this story of HISI doesn't finish here or end here. You are the people who are going to take it forward. People like you, people who are colleagues of you, elsewhere in India, every city, that is a dream, that's a vision. Every city in India should have an HISI chapter. And that is what we will be working, requesting you also in Chennai to involve other cities. Wherever the population is less, you can involve these two cities like they did in Chandigarh, Mohali and Panchkula. But that is what is. So we are also at training and fellowship programs in near future, a short-term program, distance programs and fellowship programs under NBE on infection prevention, control and antimicrobials and AMS. So that is what our. So we look forward from our hearts. That is where you can look very clearly. In fact, we invite you all, dear family members at Chennai, from my side, from Dr. Todi's side, who's an executive member at HISI Executive Board, and Dr. T.S. Jain joins as the head of the family. We invite you all, dear family members at Chennai, to join this unending saga, taking your society HISI to zenith through cooperation, selfless, volunteering, apolitical and general maturity, and understanding and scientific rationale. They are not big words. We have followed these for past 3 decades. So we experienced everything in this thoroughly apolitical approach. And the only thing which motivates or goes us is a selfless volunteering approach. And we do look forward to Vasudev Kutumbakam. So have times with your families and professionals, and professionally with your colleagues and your own profession, your careers. So we say Tathastu. And I'm thankful to Father who actually for us with right earnest. Amen. Amen. So whatever business you can think about.
Thank you for walking us through that journey, Dr. Raman Sardana. We microbiologists actually started off with a vision to form the Hisi Chennai chapter, and to give us an overview of the same, I call upon renowned microbiologist and Vice Chancellor of Sri Ramachandra University, Dr. Umasekar, to share our vision under her guidance.
A very warm and good afternoon to all of you. Good afternoon. So it's a pleasure to be here at the launch of the Hisi Chennai chapter. And also the second microbiologist meet of the Chennai Microbiologists. At the outset, I would like to acknowledge the presence of all the dignitaries on the dais, right from the CEO of this hospital to the president, secretary of the HIS, Dr. Dilip Matai, Dr. Jain, Dr. Subhash Todi, and all my young friends, microbiologist friends who are all here, and all those people, 170 people who have joined online for this program. That speaks volumes about the program itself. That speaks of the interest shown by the people in this subject today. This is the hospital infection control and prevention. As Dr. Raman was saying, it's almost 10 years before he told me that you should start a Chennai chapter and you should have an active Chennai chapter. I acknowledge that, but the gestation period has been really, really long. So I'm happy that at least today it has been born, right? And I have a team of young, enthusiastic microbiologists, infection control professionals, nurses, infection control nurses, who are all here, and they're going to take this forward. Definitely, they're going to take this forward, and it's going to be a vibrant, society or a chapter, a vibrant chapter. Yes, that's what. Infection control is not, it does not belong to any one specialty. That's outset, I would like to say. We have pediatricians here, we have intensivists here. So we have all sorts of people in this. As as Raman was saying, the admission is open to anyone, because as far as infection control is concerned, it starts from the security person at the gate till somebody who's at the exit or even at the mortuary, right? So everywhere you have the tentacles of infection control, oversight of infection control within a hospital. So not just a big hospital, as Dr. Raman was saying, it is smaller clinics and nursing homes. Thanks to COVID, everyone knew the importance of infection control professionals and microbiologists. We were the most sought after people, when COVID outbreak came, and I was, we were finding ourselves giving, guidelines and telling people, the ENT people, the ophthalmologists, the different groups of people as to what they should do and what they should not do and other things. After COVID, even the NMC has woken up, right? So they have introduced an epidemic module in the undergraduate curriculum, which never existed. And in the foundation course, just when a student gets into an MBBS, the foundation course, we have the infection control module. We start teaching them about hand hygiene, the other antimicrobial stewardship, and all those things have come. So sensitization now is beginning early. When we were students, even when we were students of MD, I'm old. So, we didn't have anything about, any teaching happening about infection prevention of control or about antimicrobial stewardship. Everything came much later. So the students are lucky now. So the government has prioritized infection control and prevention, and the government is taking steps. And I know all the medical colleges are bound to follow the mandate by the National Medical Council. So Chennai chapter, though late, I'm sure they are going to perform. Raman was listing out the activities that has been happening across India in other chapters in other states. So I have attended a few meetings. I'm one of the earliest members of the Hisi, in fact. So we have attended a few meetings, and all the meetings have been great successes, drawing people from all over India. So the Hisi as such, the National Infection Control Society was sometime in 1991. So it's been a long time since it has been formed, and at present there are more than about 1,200, if I'm right. Ah, yes. Okay. A life member. Yeah. So as far as I was looking at the directory, there are about 1,200 life members of the National Society. And of course, we have Dr. Jain as president, Dr. Sujata Baveja, vice president, and Dr. Raman Sardana, secretary. And we have a couple of joint secretaries and treasurer. This is how it works. So they have been doing a wonderful job. They have their own journal coming out, their publications, their guidelines, helping Government of India and the state government sometimes in forming guidelines. So as far as the local chapter, the Chennai chapter itself is concerned, I think first we should, consolidate ourselves, right? First, we should have more members drawn, consolidate, and get the programs going. So the idea is to have programs at least once in a quarter. If I'm not right, once in a quarter. Yeah. So we will meet up once in a quarter and probably exchange ideas and exchange. So the mandate will be to, give the necessary tools when they're not available, or when the lack of knowledge is there, provide information, right? Sharing of information, and if possible, technical resource, if possible. These are the things that I think we should be doing. Exchange of ideas. So nothing is better than a local data. If we can have our own local data and form guidelines based on our own local data, I think that's something what the US guidelines say or what the European guidelines say sometimes may not suit us at all. So we should share data on the local prevalence and other things, and share information that we can have locally applicable guidelines. That's one of the important things. So of course, none of us want our patients to, get some infection. As Dr. Raman Sardana was saying, if you say my hospital has got no infection, you're not speaking the truth. There is infection, probably we are measuring. So every hospital, I think, must have a robust system of measuring the infections, addressing the issues. What we are here is all about prevention and control. So we need to find where the loopholes are, where the problems exist, and involve everybody in the fold. So as I said, it's just not a one-man show. It's not the microbiologist show. So in many hospitals, microbiologists are the chairperson or secretary of the infection control committee, but they alone cannot do anything or perform anything. It is a teamwork. So we have the wonderful infection control nurses. I also have a team of 6 infection control nurses. So I think they are the backbone. Many of the times we call the infection control nurses and ask them about all the information and about the data that they are able to generate. I think they do a wonderful job, and I'm sure this is what is happening in most other hospitals. I was happy when Raman Sardana called them to light the lamp, and I think it's the most appropriate thing to do. So I think we should have small medical education programs. We should involve just not us alone. Anybody who's interested, it may be students, it may be postgraduates or undergraduates, anything. They have so many medical colleges here and medical institutes. We should inviting them and allow them to participate, get ideas from them. They may have some ideas. Everybody has some idea of that. So we should encourage them and organize seminars, symposiums, and continuing medical education programs. It's just about sensitization. And all of us, I think, should have involved these young people in small projects, in infection control related projects. That's how our visibility increases. When our publications increase, our visibility, it may not be, you can give them a summer project, which they can do only in the summer month. So things like that can be, so that, many people, the young people are sensitized and they are brought into the fold. So as belonging to a teaching institute, I think all these are distinct possibilities that can happen if we involve many more people into this. So I think the CSS personnel have to be brought to the forefront. They're important, the housekeeping staff, the engineers. the engineers who design the hospital, the engineers who design all your things, your OTs and other things, ORs. So all these people also must, come for meetings and, share their ideas and also be willing to take suggestions from us if we have any. So it is a challenge, infection control and prevention comes with a cost, right? To the hospital, to the management, it comes with a cost, but the cost is nothing when compared to the cost of treating an infection, right? So the cost of antibiotics, per day, the treatment cost or one course of treatment, what happens. So prevention is always better than cure. So I think every hospital must be able to invest that cost in the infection control program, bring in enough number of people, enough nurses, enough number of infection control professionals, infectious disease professionals, and all these things. And that's when it will be a successful program. So I think the formation of such chapters is to a step forward. Actually, it is in the integration of members and dissemination of infection among members all over India. One other suggestion that I would like to offer is when another chapter anywhere in India is having their program, they have a CME or something like that, can be telecast live for the other members from other chapters so that they can also, online. After all, it is an online digital world now. So from anywhere we can, access these programs, or there should be a repository of, such lectures, modules, and other things so that, people can access anywhere. So it is our activity need not be, pertaining to ourselves alone. So this can be disseminated. So I'm sure all the programs are happening across India. So as Hisi members, all of us can have access. And if we have the time and of course the inclination, we are going to join and we are going to listen to them and we can, exchange ideas. So another thing is the antimicrobial stewardship that Dr. Raman was talking about. That again, Government of India is giving a lot of emphasis. The government knows what it is now to have this, this thing creeping up. So not creep, it was already in. So I think that is another thing that all of us have to stand up and, stand for. And we in each of our hospitals, we should take this program seriously and see whatever we can to implement the antimicrobial stewardship program. And of course, all the risk factors and behavioral problems have to be addressed so that, health for all, according to the Indian government, can be achieved to some extent at least. Overall, at least, the WHO says at least 10% of, people admitted into the hospital get one infection or the other because of the hospital. So some hospitals can have a very low infection rate, some can be high. So if we don't measure what we are doing, we don't know if it is there or not. So measuring is the first thing, right? Every hospital should measure what's happening and then address if there are issues and address. So at present, there are about 29 members, 27 or 29 members in the Chennai chapter. And I'm sure there are so many more microbiologists in Chennai, so many more infectious disease specialists, so many more infection control nurses. I think our numbers should grow first, and you should, grow at least about 100 to 200 people so that whatever yes, it is possible. I think it's a question. This time, I think Shubha, her team, Anusha didn't have enough time to get the message around to see that this chapter is being formed and, induct people. So I think we can do it. So I think there are enough people in and around Chennai. I think we can do that. We should have more members. And then the discussions become more meaningful, the message is carried more powerfully, the become more meaningful. So I think we have made a beginning, right? There's no denying the fact we have people, the national chapter coming and, opening up this Chennai chapter. So it is an auspicious beginning. It is a good beginning. And I'm sure we are going to have more people, more discussions, more education, more programs. And I'm sure we're going to take this forward and be a very, very vibrant and, excellent chapter. And soon we are going to overtake all other chapters in our activities. So thank you all once again. And I'm really, really thankful to Dr. Anusha for having extended this infrastructure and other places for the launch of the Hisi. And I'm sure the next quarter, we're going to meet again and we're going to deliberate on a lot of other things. Thank you also.
Thank you, ma'am, for the grand vision. We promise as council members to see it through before we pass the baton on to the next group of people who will take on the role from us. I'd now like to introduce you all to Professor Dr. Dilip Matthias, stalwart in infectious diseases with over 35 years of academic service. And he's been working as the Dean of Apollo Institute of Medical Sciences, Hyderabad. And he's a distinguished professor and in the advisory board of many hospitals and universities, including the Madras Medical Mission. Thank you, sir.
Good afternoon, Anusha, and respected dignitaries on the stage and my colleagues and friends. I really don't know you. Several items have been presented. I don't want to repeat them. I'm not a pulpit speaker, but however, I am going to borrow the 10 commandments. But I don't want to narrate the 10 commandments. I will make it 3 commitments. So what are the commitments for infection control? Any hospital that espouses that we are involved in quality, the number one, there are 10, but the number one is infection control. And why do I say number 1 is infection control and number 2 is medication errors, number 3 is code blue, and number 4 is diagnostic errors, and etc. Number 1 is infection control simply because the outcomes of infection of an infected patient admitted into the hospital is terrible. Secondly, we have got several interventions available to prevent this infection, also improve the outcome. So that is why I keep saying that infection control is the number 1 priority of any hospital that espouses quality. Having said this, how do I now bring in my 3 commitments to infection control? First one is, yes, you must have commitment. What is the commitment? Commitment is to strategy. I know CEO sir is with strategy. But what is strategy? Strategy you have to formulate. And strategy you have to implement. If you do not have a strategy, and if you do not have implementation, you are a failure. Let me give you an example. We have got community medicine people. Now, let's say malaria no more. MNM. Malaria no more. Now, what does it mean? Yes, Modi ji has said by 2035, HIV, by the way, I'm president of the AIDS Society of India, I have brought down the rates, but it's still not possible. 1,000 infections occur each year in my country. Now, you look at TB. We're trying to eliminate TB by 2030, 2025, 2030. You're only bringing down the numbers from 144 per 100,000 population to 44. Similarly, for malaria, I went to the national NCDC, now called the CDC of India, whatever it is. Sir, you are reporting only 1,000 deaths per year in my country for malaria. Why should I teach malaria to my medical students? No, Dr. Mathai, there may be more. But then why are you not reporting? People are reporting malaria. So having said, we do not know the number, but if you look at sales of anti-malaria, 10 times the number. If you look at the deaths, I know hospitals have been saying that there are deaths in malaria, but nobody accepts it because of administrative reasons. So today, I am not saying anything about what should be our infection rate in any hospital. When I say I do not want a multi-drug resistant organism in your hospital, how many people are with me for that? I can understand if you have Staph aureus. I can understand if you have acons because they are commensals. Absolutely no business for an MDR, multiply drug resistant organism, to come on my surgical site infection, to come into my tracheostomy. It's all poured in. So I am not asking for zero tolerance to infection, but I'm asking for zero tolerance to MDR. That is the one. So if strategy, You must have a goal for that strategy. And the goal for the strategy in my Bible, MDR should be 0 in any hospital. I'm not worried about Clostridium difficile. I'm not worried about VRE. I'm worried about MDR, simply because these organisms have been created by us. Simply because we use, I'm not calling high-end, we use broad-spectrum antibiotics, which subjugates or destroys all your commensals, and these guys emanate. So strategy number 1 for any hospital is do not have an MDRO, particularly gram-negatives. Secondly, staff. Now, second part of my commitment talk is there should be passion. If you are not committed passionately, you cannot bring in a good infection control program in any hospital. Now, what do you mean by passion? I'm in internal medicine, microbiologists our training competencies are different. Microbiology is trained under, let's say, so I was trained under, let's say the physicians, okay, and microbiologists are trained under, let's say, Louis Pasteur. Now, for them, it is hygiene. They're excellent at prevention. The medicine guys are not excellent at prevention, but they are excellent at curative. We are bedside, we are bedside. We are excellent in terms of making a clinical diagnosis, simply because I love pathophysiology and physiology. Microbiologists are excellent in making a diagnosis of the causative organism. They are excellent in AST. Today we're listening to that, AST and MIC. But we are interested in the PK/PD of antibiotic. We are more involved in terms of seeing the patient eyeball to eyeball. But they are also educators, but only if they would come to the bedside and we go, or they come to the bedside and we go inside. If these two do not meet, you can never have a good infection control policy. It's nothing, there is no big deal. The job of an antimicrobial agent today is only to annihilate the organisms which you grow. If you don't grow anything, we clinicians, 0. So what do? We go in for empiricism. Microbiologist has not grown, we go for empirical therapy. Okay, we have got some surrogate markers. We go for presumptive treatment. Oh, microbiologists have grown, then we go for focused treatment. So if you grow, then we'll have a focused treatment. So you see now, unless you have, I know today is the second meeting of the Microbiology Society of Chennai chapter, but you have to have meetings with the physicians and with the surgeons and whoever is caring for the patient and ensure that you have institute these good practices. The third one, which I would say, is commitment to developing competencies. Now, what is the competency that we teach? Knowledge, skills, and behavior. That's easy, knowledge, skills, and behavior. But unless you have these competencies within you develop, how do I develop? Nobody has congenital knowledge. All knowledge is acquired. How do you acquire knowledge? By reading or by being taught by somebody. We seldom teach people how to get these competencies. Now, I teach there are only 6 principles of infection control. Nothing more, only 6. Number 1 is hand hygiene. Make sure that you practice hand hygiene, if possible, patient hygiene. Second one is environmental cleaning. Make sure that your environment is clean, not in terms of aesthetics alone, microbiologically clean. Clean if you have to. Third one is disinfection and sterilization. Master it. If you master disinfection and sterilization, you've gone 2 steps ahead. Fourth one is practice aseptic precautions before you get into the central line, before you put in an intercostal tube, before you do any form of a surgery. The fifth one is in terms of making sure that you practice care bundles. Care bundles is something that you should, there are so many care bundles. I'm not talking about antimicrobial stewardship as a care bundle, but you should ensure that you practice these care bundles as such. So who is to train them? Who is to train them in each of these activities? Because what I find is that you must develop that degree. I'm terribly motivated, but my motivation can die anytime. When I was 17 or when I was 23 and I started infection control, my first job was to keep the hospital clean of monkeys, bandicoots, cockroaches, rabbits, and dogs. Then I moved into getting them clean with this microbiological agent. 45 years I've been practicing infection control, never succeeded. But Dilip, never say die. You were 17, now you're 71, only the numbers have changed, not to worry. So now I'm looking at small data. I've got limited time. My motor gadi chalega till 80-82. So during this period, I want to make some small impact. And the impact that I want to do is to ensure that I remain sufficiently motivated. At the same time, have a discipline. Motivated is good, but discipline is not there. I think the key word for infection control is discipline. And if you can do that, brother, my grandson would be safe in any hospital. Thank you very much for your patient listening.
Thank you, sir. What you shared today is probably the need of the hour, and it is our duty to translate your vision into reality. When it comes to life, the critical thing is whether you take things for granted or you take them with gratitude. Expressing gratitude is important, and to propose the vote of thanks, I request Dr. Shubha S. to take the stage.
On records, you mentioned two started from Mumbai who were very instrumental in HISI formation. I think and thank of Dr. Chennai. So he is no longer the guy that a great woman, woman of substance. And also thankful to Dr. The school, I think, opportunities I never met, but so always parallels. So third years of the parallel, these were great scholars at that time before. So thanks a lot to them that today we are standing in front of you, and also Dr. People like Dr. Boni Kilter, Dr. People in class from Mumbai. Who are still doing a unit of as far as education.
Very good afternoon to one, and it gives me immense pleasure to deliver this vote of thanks. And I would not take a long time. I just thought very key important points, or a little a note on what got to the light of this day. And the first and foremost thanks is to the organizers, our beloved Dr. Anusha and her team, the management. If it is not then, this day was not possible at all, because it's a task. Or rather I was very skeptical in the very little 2 weeks time that it's what it is today. And I was really worried whether we can do it, or rather Dr. Anusha did it very well, and it's going on very well. So we need a big round of applause for Dr. Anusha and her organizing team on site. It's not easy task. So that's the first person. And coming again, how the journey, a couple of lines of what got us together here. So we always realize that in life, we receive a lot and we give very less. And for that, only gratitude can add richness to our life. And I'm so happy that this little part, I got to do it. And gratitude is, I'm sure if you will agree, is the parent of all virtues and the greatest one. And having said that, when I think a couple of us microbiologists, them this an idea, and the idea of coming together as microbiologists to start with came over a coffee when we were in another conference last year. I thought it's high time that we come again. It's not about only microbiologists. But we had a lot of technical difficulties, which definitely clinicians would find boring stuff to discuss in a forum. So that's the whole point. There's this one friend of mine would tell something, how do you do this? And then we give our, you try in the other system and then put this control, put that. So obviously the other people is not going to be happy with such a talk. So that was the starter of coming together as microbiologists. From what I know, I've been here and like for the last 13 years, but we don't have a forum of ours to talk our technical stuff. I will be more than happy if when we are talking the technical stuff, if clinicians out there are interested, I don't think, I would say no to that. So that beginning of Chennai Microbiologists Meet, and we just started a WhatsApp group. It started with some 10, 15 of us. And in March meet, it was 56. When we made it as a group, although in person, we did have some 20 to 26, but still it was a very good start. And then with that quarter idea, we proposed to, and Dr. Anusha was very kind enough to volunteer to host this. And that's when we thought we need to expand ourselves. We need the clinical team. And we had a big challenge on the infection control aspect, which needs a better forum to discuss. And that's when we were looking at Hisi, and Dr. Yamuna is not around today in person, but she was a great strength to lead us in the right path to get us to the Hisi India so that we take on the right route. So that's about the beginnings, and we definitely needed that great leader. And Dr. Uma ma'am has been like a source of inspiration to all of us right from PG days. I knew when I was a PG, or rather first academic, I shouldn't think this, but still first academic conference that I came to Ramchandra for my first microcon in my PG days. So I had kept ma'am as the source of inspiration. We requested, and ma'am was more than happy, someone to just and take this forward. All we needed is that, if you call it as a child, to cross the road, a busy traffic road with no cross lines. And we just needed that person to be along, and ma'am is there with us with no interruptions. Go and say for everything right. Okay, go ahead, try it. And I think that's what we want. And we have the best leader. And Dr. Tyagarajan sir for very humbly joining this team. And we can't ask for the leaders. And then comes our like Kirpa, Aarti. Manisha is not here. She got her transfer from ESI Chennai to Hyderabad. Otherwise, it's like in the first 4 months when we're coming together, I think they were a real great strength. I was always skeptical. Are we doing right? Is that right? I think that's been there even till date. But it's this people, they're like, come on, go ahead, hesitate. I just love this people around. And we want the same support and strength from all across other specialities. We have our nurses, our CSST personnel, and our juniors all along with us. I'm sorry if I've missed to mention anybody in this. And then comes our Hisi strength, Dr. Raman sir, Dr. Jain sir, Dr. Todi sir, who's here. Apart from the busy schedule, they saw to it they are there in person, and that's a big honor support to us. I don't think we can ask for anything more. And last but not the least, the delegates on site and online. I think without this great support of each one of you, this day's success, it's already a success. Thanks to each one of you. Thank you.
Shiva. And now we will start the scientific session. I request the dignitaries to take their seats in the audience. First, have always been using the CLSI guidelines because that's what we've been exposed to. But in 2019, I met Professor Gunakata, and he was kind enough to accept two of us, that is Dr. Kalyani, myself, to do an observership in his lab. And that taught me so much about antibiotics and all that I had been carrying out for the past 10 years. And that was the turning point to which I thought I should ask someday, get Dr. Guna to come to India and to talk to all our microbiologists here. I know this is not a national conference, but we have 200 microbiologists listening to you, Professor Guna. And thank you so much for accepting this invitation. We hope to see you present here someday. And over to you for your scientific session. Professor Gunnar Kalmeta, Head of UCAS Development Laboratory, Växjö, Sweden. He is also the UCAS Technical Data Coordinator and Webmaster. He was the former president of ESCMID and the former chair of UCAST. Welcome, Professor Gunnar, and thank you so much for accepting this invitation. I hand over to you.
Thank you so much. Can you hear me?
Yes.
Can you see my slide?
Yes.
There is an echo, which is probably because there is an extra microphone somewhere. So maybe if the technician can kill that microphone. Okay. Dear Anusha, dear esteemed colleagues in clinical microbiology, infectious diseases, and infection control, it is indeed a pleasure and an honor to be allowed to join you on this important day. I wish I could have been with you, but that was not possible this time. Anusha has asked me to give you a little bit of an overview of what UCAST is all about, but also to maybe compare UCAST and CLSI. I'm not going to be nasty to CLSI in any way. I'm just going to try to be very objective and move some of those advantages of CLSI forward and some advantages of UCAST forward. And I will leave it up to you to then find out more about such a comparison. So I've been with UCAST since 2001. I've actually been with UCAST in 1996, but I was asked to chair in 2001. I chaired for the next 10, 12 years. Then I became the president of ESCMID, and I relinquished my UCAST chair, but continued in the background as the technical data coordinator and webmaster, and I still am. I'm also, since the very beginning, heading up the UCAST Development Laboratory in Sweden. I have a long tradition in clinical microbiology. I started out in the University of Lund in southern Sweden in clinical microbiology in 1971, and I have been active since then. I've headed up 3 clinical microbiological laboratories, all of which I have built from the first stone to the last. So, UCAST, the European Committee on Antimicrobial Susceptibility Testing. It started out very European, but as the years have gone by, more and more people have asked to join us. And today we have people from all over the world join UCAST and use UCAST guidelines. You will find everything you need on www.ucast.org. All the guidelines, all the breakpoint tables, all the methodology, etc., etc. And it's worth spending a few evenings browsing the website just to see what is actually there. And even though you may be on CLSI guidelines, you will find lots of general information and help also on the UCAST guideline. So it's the UCAST website to the left, and it's the CLSI website to the right. UCAST is organized by ESCMID and ECDC, and ECDC, of course, is the European Center for Disease Control. And early on, they decided to back UCAST, and today they accept AMR data only when produced with UCAST guidelines. It's multinational, way outside Europe, New Zealand, China, Australia, South Africa, etc., etc. So you will find UCAST in many countries around the world. It's run by the profession with input from agencies, and agencies are, of course, ECDC, as I said, but also the European Medicines Agency and the European Food Safety Agency. It's not influenced by pharma companies. The pharma companies do not have a seat on any of the UCAST committees, but they are asked to present cases. To be quite honest, we normally have a pharma presentation at every second steering committee meeting. So we work closely with pharma, but they're never part of any voting or any decision making. Everything is freely available on that website. You don't have to pay, you don't have to leave an email. You can go in and out as you like. The website is updated in real time, and there is reason to put something on. It could be a new document, it could be new guidelines, it could be a revised breakpoint, it could be a revised rationale document to describe the reason behind a breakpoint, etc., etc. And that happens almost weekly, and there is an automatic monthly newsletter which you can sign up for. UCAST is democratic and it's open. Anyone can serve, everyone can express opinions, and colleagues are invited to interact in the process and methodology development. There is a network all across the world where we utilize the fact that there are experts on various rather nerdy issues such as nocardia or the importance of pH in susceptibility testing, etc., etc. You will find these nerds or experts all around the world, and we try to engage them in the UCAST networks, and we try to utilize the fact that they are there and that they have that specific knowledge. Also, we recognize that if we need lots of Vibrios for a development, then we need to go to the countries where Vibrios are rampant. And we normally contact the national reference laboratories all around the world. And we say things like, could you supply a number of isolates for each of these 5 Vibrio species, and be part of a development program for breakpoints for Vibrio, just as an example. Recently, India was one of these laboratories or one of these nodes that supplied, in this case, particularly Vibrio. On another occasion, we asked for Corynebacterium diphtheria and Corynebacterium ulcerans, and that's just explains how we work. We try to include people with expert knowledge. We try to include people with a variety of isolates and strains that are representative for many areas of the world. And in that way, we can move forward and involve more and more people. We have 2 dedicated development laboratories that function as nodes in those networks. One is for bacteriology, and that's the one I'm heading up, and the other one is for fungi, and that is headed up by the expert Maiken Kavling-Arendrup. So we take on development and we troubleshoot methodology when people complain about the fact that sometimes it doesn't work the way they had hoped. UCAST is run by a steering committee with 12 members representing a number of different countries. There is a general committee with a representative from each country and a national AST committee network where we encourage countries to form national AST committees with which we can communicate about a variety of issues such as education, translation, workshops, posters, etc., etc. We have 5 meetings per year, and in the old days, they were all physical and we would travel to different cities. Nowadays, some of them are over Zoom and others are still physical. We consult publicly via the website on every major decision. So whenever we are changing breakpoints or deciding on new breakpoints, we will post a consultation for typically 6 to 10 weeks, and we will ask colleagues to give us their views on our proposed decision. There are now roughly 160,000 page visits per month. And there is another specific website for MIC distributions, but it can be accessed from the general website. Green is good. The green countries have reported back to us that now more than 90% of their laboratories are on UCAST. And down at the bottom, you can see other countries outside Europe, and you can see that there are several of those that are also on UCAST, but quite frankly, we have lost count, and I'm constantly reminded by people from various countries that we're also on UCAST and we're not on your slide. The current chair is Christian Giske. Mandy Wootton took over as scientific secretary from John Turnage from Adelaide in Australia, and Mandy is from Cardiff in Wales. Raphael Canton is the clinical data coordinator. You've already met me. Shampa Das is one of our PK/PD experts, and so is Joseph Meletiadis. And then you have some people representing various national committees. This is the national representatives on the General Committee. And as you can see, there is room for India once you have decided that you want to form a national committee and that you want to sign up with UCAST. It has nothing to do whether you decide to change to UCAST from CLSI or not. It has only to do with whether you want to be in, let's say, in organized contact with UCAST to be informed about news, new guidelines, etc., etc. There is no commitment, there are no promises, and there is no money involved in joining. It's just joining a herd of people who are interested in moving guidelines forward. There are subcommittees on antifungal agents, there are on antimicrobacterial agents, veterinary agents. There is a subcommittee on the relationship between phenotype and genotype, and there is a subcommittee on MIC distributions and the setting of epidemiological cutoff values. I tried to compare UCAST to CLSI, and I've had this slide for almost 20 years. It changes over time, and you have to be a little bit cautious about what you put on there, because in fact CLSI is in many ways trying to emulate some of the stuff that UCAST does. So UCAST is completely free of charge and has been since it started. CLSI is now trying to launch a number of documents that can be free of charge and available on the website without logon. But if you want the full package, you still have to pay for guidelines. UCAST is formally acting for the European Medicines Agency. That means they have already decided that they do not want a committee of their own. They are happy to take the advice from UCAST. And so far, since daptomycin in 2002, 2003, EMA has accepted all the breakpoints proposed by UCAST. CLSI has no formal standing with FDA, which means that in the US there are FDA breakpoints and there are CLSI breakpoints. Some of them are the same, but quite a few are different. We have no industry involvement with UCAST, whereas with CLSI, it has a long tradition of being moved forward together with industry, and industry has had a very important and powerful role on the CLSI committee, which they are now trying to reduce. We have the public consultation process. This is not present with CLSI. We have a timetable for a systematic review of breakpoints, which we find is absolutely necessary, whereas CLSI will review and sometimes revise as suggested by colleagues in various places, but it's not systematic. We have 5 meetings per year, and CLSI has 2 meetings per year. We have an organized collection of MIC distributions, which now consist of 30,000 distributions from all over the world. And we determine ECOFs in a very formal process and make them available on the website. So clinical breakpoints determine the susceptibility of the microorganism against a specific agent. All methods are dependent on breakpoints. We have phenotypic test methods, which is what many of us use on a daily basis. And then for some specific organisms or specific resistance mechanisms, we use a genotypic method. And the difference between the two is that the genotypic test methods are good at detecting the gene or its product. It will not quantify susceptibility or resistance. It predicts resistance, but cannot predict sensitivity, and it's extremely useful for epidemiological purposes. Phenotypic test predicts both susceptibility and resistance, and it's also importantly quantifiable when outside the wild type distribution. So you can say things like, this organism is less susceptible than that organism because you can quantify the phenotypic activity needed to inhibit the growth of the microorganism. Both require standardization and agreement, but phenotypic test methods without standardization and without agreement are worth absolutely nothing. Then we have expert rules and expected phenotypes, and we say things like, if MRSA, then report resistant to all beta-lactams except ceftaroline and ceftobiprole, for example. Some rules predict susceptibility, most of them predict resistance. They are absolutely unreliable in the history of things because they change over time, and they're certainly not quantifiable. But it's important to remember that all these methods, whether they are phenotypic or genotypic or expert rules, are dependent on clinical breakpoints. So who is in charge of the breakpoint process? Well, it depends on national legislation and or professional agreement. There is no such thing as international legislation in this matter. In Europe, it has been agreed that the European Medicines Agency is in charge, but as I said, EMA will accept UCAS decisions on breakpoints. In the US, FDA is in charge and does not accept CLSI decisions. In the UK, MHRA decides but accepts UCAS decisions. And in India, I would take it that the Central Drug Standard Control Organization would formally be in charge of breakpoints. But as informed by Anusha, most of you are on CLSI and you will accept, and probably the Central Drug Standard Control Organization will just let it slide and accept that everyone considers the CLSI breakpoints the standard. But it might be good to know that CLSI and FDA are not in agreement on breakpoints. Internationally, no one is in charge, and at home, every colleague knows best. There are today, to the best of my knowledge, two international breakpoint committees. It's the UCAST and the CLSI. So a clinical breakpoint is an MIC value which distinguishes between isolates which can and which cannot be treated with an antimicrobial agent, to put it simply. The definitions of S, I, and R is now that we have in UCAST 2 susceptible and 1 resistant category. So S and I are just different degrees of susceptibility. And if you report an S in the UCAST system, it means that the agent may be used at a standard dosing regimen. Or if you like, you don't have to think very much about the dose unless it's an infection in a tough compartment. But otherwise, this bug is fully susceptible in every which way, and standard dosing should solve the problem. Whereas if you report an I, it's still susceptible, the agent is still useful, but you need to think about the exposure. You can do that by manipulating the dose. You can do it by manipulating the mode of administration, etc. So there are various ways of increasing exposure. And the R, of course, means that the agent will most likely be ineffective and should probably not be used. So this is a typical UCAST slide. In the background there is a distribution of 37,642 observations, meaning MIC values on Streptococcus pneumonia from 32 different investigators all across the globe. The clinical breakpoints from UCAST are S less than or equal to 0.064 and R more than 2. The ECOF, which is here, is 0.064. And you can see that the distribution of MICs is divvied up in 3 categories, as I said: susceptible at normal exposure, susceptible at increased exposure, and resistant. Having said that, it's important to remember that MICs are not absolute values. Any change in a system, whether it's the pH, the incubation time, the content of cations, the type of agar you're using, or the type of broth you're using, that will most likely result in a change in the MIC. And whenever you use other methods than the reference method, materials and devices must be calibrated to the reference broth microdilution MIC method. And that goes for disk diffusion, that goes for for gradient tests, for semi-automated devices, and of course for all the new devices which are now coming along, trying to cut incubation time from 16 to 20 hours down to maybe 10 hours, 8 hours, 6 hours, 4 hours, and even 2 hours. The final responsibility for producing a correct result and a correct report lies with the clinical microbiologist. But of course, the interaction between the microbiologist and the company which provides whatever we're talking about, it could be a device, it could be a Vitek 2, it could be a Phoenix, it could be a disc, it could be a medium. The interaction between the clinical microbiologist and the producer of those materials is going to be extremely important. Whenever you want to calibrate surrogate tests, tests that are surrogate from the point of view that they are not actually the reference method, they are a method which can be calibrated to the reference method, and then you should use the rules in the new ISO document, which can handle truncation and which can importantly calculate bias, because it turns out that a lot of the devices that we have come to depend on are actually fine in one area of the MIC scale and sometimes not so fine in another area of the MIC scale. And quite typically, they will handle quality control strains, ATCC strains that are normally wild type from a resistance mechanism point of view. They will handle these strains fantastically well. And then we get into trouble as we get close to the breakpoint. That goes for colistin, that goes for benzyl penicillin, that goes for a number of agents and species. And it's important to keep an eye on when it works and when it probably will not work. And on the website, on the UCAST website, there is a section called warnings, where we try to keep an eye on those things that don't work so well and inform colleagues about problems we've discovered. We're not equipped to systematically look at all media, all devices, etc., etc. So it will have to be potshots from afar, and often it emanates from a colleague complaining that he can't make whatever we're talking about work properly. In UCAST, the target species are very important. We will not set general breakpoints that goes for everything. We want to know from the company, from EMA, what species do you consider important for this new agent? We want to know whether E. coli is a prime target, whether Enterobacterales on the whole is a prime target, whether Pseudomonas are included among the targets. We want to know whether the agent is supposed to work against both gram-positives and gram-negatives, and in that case, which of these. So we want to define the target species. And in this case, we're looking at ciprofloxacin and E. coli, and you can see down there at the right-hand corner that there are 16,000 MIC distributions from 55 data sources. So we're pretty confident that we're looking at a reasonable distribution, and we've set the ECOF at 0.064. The clinical breakpoints are currently 0.25 over 0.5. But some of you might remember that both CLSI and UCAST started out at 1. So we're sort of gradually working our way down, and that's typical. We're always over-optimistic in the beginning, and then as the years go by, we learn to the necessity of moving the breakpoints down to a more realistic level. So you've got the ECOF with the black arrow, you've got the clinical S breakpoint with the green arrow, and the clinical R breakpoint with a red arrow. And this is just to show you that you can do exactly the same, and you can do that for gentamicin versus E. coli. You can see the wild type will be somewhere between 0.2 and 2. You can see the resistant strains out there at 4 and above. And you can see that if you take the ATCC strain 25922, which is the regular strain for QC, both with CLSI and UCAST, you can see that if you repeat test that over and over again, you will actually have the same distribution, 0.25 to 2. So there is very little biological variation inside the wild type. And that makes it very important to treat the wild type as an entity when you set breakpoints. This is not something which is part of the CLSI strategy yet, at least, but in UCAST, we would never set a breakpoint that divides a natural wild type distribution where the bugs do not have any resistance genes or resistance mechanisms at all. We would never divide such a distribution by inserting a breakpoint in the middle of it. To the far right, you can see how the disk test actually copes, and you can see that the disk test will distribute the isolates in a very similar way. And of course, the more sensitive isolates are here to the right, and the more resistant ones to the left, whereas with MICs, it's the other way around. And this is just to show you another one. This is meropenem and E. coli, and you can see exactly the same type of pattern for each of those. Let me just share with you some of our more recent projects and achievements, and all of those can then be found on the website. Of course, you can find the clinical breakpoint tables. They're updated the 1st of January every year. You can find the content and you can see all the different tabs. You can click on a tab like Pastorella SPP or Kingella kinga, and you will go directly to the tab describing the breakpoints for that specific bug. So over the years, we dealt with one agent after another, one agent group after another, and then one group of species after another. And together we devised a format for how to tackle the setting and systematically revising of breakpoints. And we sort of got into a rhythm, and we discovered the importance of having a system for doing this and not leaving certain agents or certain species behind. We never vote in UCAST. We continue to discuss and look for evidence until every member of the 12 members are convinced that we're on the right path. And these are just the agents we have dealt with. We've actually dealt with some more than these, but some never made it through the EMA process and never made it through the registration, and thus they are now dead from that angle. And I haven't listed all the antifungal agents that the subcommittee for antifungals have dealt with, but you can see them down there in the right-hand corner. And we've dealt with all these species, Enterobacterialis, Pseudomonas, Acinetobacter, etc. And you work your way down the list and you will find Achromobacter xylosoxylans, Neisseria, gonorrhea, and meningitidis. And we're now digging into the anaerobes for the second time, and this time we're developing a robust disk diffusion method for the anaerobes, which will save colleagues from having to take gradient tests or whatever other tests they might have to these bugs. And that methodology has just recently been field tested in 17 laboratories across the world, and it works fine. Then you can see the Vibrio project with the 5 most important Vibrio species, including Vibrio cholera with and without toxin. And we did Vibrio cholera together with CDC in Atlanta, and they did the toxin producers and we did the non-producers and all the other species. And we managed to agree that the methodology was fairly straightforward, and UCAST were able to set breakpoints to Vibrios. We had Corynebacterium from before, but they didn't include Corynebacterium diphtheria and ulcerans. So in a large project where we involved a number of reference laboratories, we managed to produce 400 MIC values on diphtheria and ulcerans. The same with Burkholderia pseudomalae, together with laboratories in the Northern Territories, in Australia, and in the Far East. We managed to test 350 roughly Burkholderia pseudomalae, both with MICs and disk diffusion, and I'll show you one slide from that as well. Mycobacterium tuberculosis is ongoing, Nocardia is ongoing, atypical Mycobacteria ongoing. We have just finalized Bacillus anthracis and Brucella melitensis, and those breakpoints will be available in January. And these are just some publications of methodologies. This is to show you that in the breakpoint table, there is a tab where we list what we consider the standard dosage and what we consider the high dosage of respective agent. And also when there is a specific dosing for uncomplicated UTI, there is a specific column for that as well. And this is not a therapeutic guideline. This is just to show you what doses did we consider when breakpoints were determined. Because as you may imagine, every breakpoint is related to a dose, or rather to an exposure. So the whole idea of having susceptible dose dependent is a little bit crazy, because all breakpoints are dose dependent. This is to draw your attention to the fact that we consult on a regular basis. And anyone who's interested in the process and in what happens can go to the consultations website on the UCAS website, and you can see what consultations are currently active. And you can also read and see all the previous consultations and how we responded to those. And you can see that there will be consultations on viridans, group streptococci, and on nocardia eventually. And there will be a consultation on a dosing tab similar to this one, but for the pediatric field later this year, hopefully. So we've talked about these, and I'll just show you a few distributions on how we ascertain that the breakpoints will work in real life. So this is the 5 Vibrio species. You can see the zone diameter distribution from those 371 isolates, and the distribution is painted in the colors of each strain's MIC value. So you can see that anything to the right of that dashed line has MIC values in the area of 0.06 to 0.5. It's common with a 10 log for the distribution of the wild type. And you can also see that those isolates that have higher MICs of 1, 2, 4, and 8 and above, they are red or orange, and they are to the left of the zone diameter 14. So when we look at this, we can see that this is a fairly robust method. It will still need standardization in the laboratory that will utilize it, but it's not going to be a very tricky test to make work. Here's another one, and this is for ciprofloxacin, the 5 microgram disc, same 371 isolates. And you can see that almost all the red and orange isolates are to the left of the dashed line, whereas a few are actually right in the middle of the population. And that's something we see once in a while. And people will automatically think that the MIC is always right, but I put it to you that the zone diameter is actually more often right when there is a discrepancy than the MIC is. It's just that we're so impressed by the MIC because it has three decimals. It's portrayed as being very exact, but quite honestly, it has a number of difficulties with reading endpoints, and the fact that it is dependent on forming cloudiness in the broth. So this is probably as good as it gets for ciprofloxacin. Here's tetracycline, and you can see that that seems to work fine. And that was for Vibrio as well. And this is ciprofloxacin for Corynebacterium diphtheria, and you can see that there is a wild type there. And you can see that there are some resistance, and the same for benzyl penicillin. You can see that there are resistant strains with MICs of 2 and above. And when we look at the disc diffusion results, we get a nice wild type distribution in various yellow hues. And then to the left of the dashed line, which is the breakpoint that was decided, then you can see that there are the resistant ones are down there and fairly easy to separate from the ones that are wild type and do not have resistance mechanisms. All of these distributions are available to you on the UCAS website. And if you have any problems finding them, just drop me an email and I'm happy to help. There are more than 30,000 distributions, and they've all now been curated, and all the ECOFs have been revised, and that was finalized only very recently by John Turnage and myself. So disc testing of anaerobes we talked about, and maybe just a few words about rapid AST directly from positive blood culture bottles. We can now actually do regular disc diffusion directly from blood culture bottles. As soon as they go beep, beep, beep in the machine, we can take a volume out of the bottle, seed it onto a Muir-Hinton plate or a Muir-Hinton F plate, put discs on, incubate, and a number of species such as E. coli, Klebsiella, and Staphylococcus aureus can be read already 4 hours after 4 hours of incubation. Pseudomonas will require at least 6 hours. But for many species, we can actually read already after 4 hours, which means we can give a report to the clinician 4 hours after the bottle went beep, beep, beep in the machine. There are some breakpoints for new agents under development. There are some new agents under development, and we don't know which of these will actually fly, but all of these are being looked into. There is a continuous review and revision of breakpoints for existing agents. There is a discussion on dosing for cephalosporins in Staphylococcus aureus ongoing. The term intrinsic resistance has been abandoned because no one could agree what it was. And instead, we have coined the phrases expected, susceptible, and expected resistant phenotypes, and there are definitions of those on the website. And we talked about the dosing tab and pediatric dosing. This is the UCAS development laboratory and my co-workers, Jenny and Erica and Onur, and we are always happy to develop methodology further, to troubleshoot materials, troubleshoot devices, but we're also always keen to try to help you out with difficult isolates. And we take isolates from as far away as Sao Paulo, Budapest, etc., where people have difficulties deciding whether they can use this agent or that agent. That was Pseudomallei. And I think this is the last slide. It just shows you some of the publications that was made in the Journal of Antimicrobial Chemotherapy quite recently, on how rapid AST directly from blood culture bottles actually works. The development is described, but also a clinical trial in 55 laboratories from all over Europe, Turkey, Greece, Italy, southern France, Spain, the Nordic countries, etc. And I think with that, and these are the two publications in the Journal of Antimicrobial Chemotherapy. And with that, I say thank you for listening.
Thank you. Sorry. Is this better? Yes. Okay.
Better, yeah.
So if there are any questions to Professor Guna, online we will be able to see them on the live chat. You can put your questions in and I can read them out. Any questions from the audience here? If there is a delay, I will email it to Professor Guna and get back to you on the question. You can always email us asking your question and we will transfer it to Professor Guna. And something that, Professor Guna, something that everybody asks me many a time is the fact that how do you choose your wild type strains? And this is something I'm not able to give an explanation to. Maybe you can help me out there.
Yeah, I can help you out. If you go into the UCAS website and look at any agent, any species, and we saw the E. coli, for example, against gentamicin. We saw the Corynebacterium diphtheria against ciprofloxacin. Actually, we don't have to choose the wild types. They choose themselves. They present in a very specific way. And with statistical analysis, we can differentiate between what is wild type and what is not wild type. And then we can test that by testing the upper end of the wild type, because that's where the resistant strains would be if they were not wild type. And we can test the upper end of the wild type by genetics or by, a number of different methods. So I'll just give you one example. For example, Salmonella enterica against fluoroquinolones, the most sensitive way of detecting whether a strain has one or two or several genes against fluoroquinolones is to use p-floxacin. And so we can test each of those wild type distributions and ascertain that they are true wild types and nothing else. And we've also discovered that it doesn't matter who sends the strains to us. We have salmonellas from seals in the Black Sea. We have E. coli from seagulls on the coast of Chile. We have E. coli from perfectly normal women with urinary tract infections. And all of these strains behave exactly the same, exactly the same. It doesn't matter where you collect your E. coli or your salmonella or your Staphylococcus aureus. The difference between countries, the difference between areas, the difference between different animal species and humans is not in where the wild type is portrayed, but the rate of resistance that appears in the different materials. And I'll give you an example from 25 years back where we performed a study together with some Indian colleagues actually on the west coast of India, where we looked at Haemophilus influenza and Streptococcus pneumonia against a number of agents. And when we looked at trimethoprim sulfamethoxazole, 95% of the strains in my area, which is a forested area of Sweden, the children there, 95% of the strains were wild type, whereas in Pondicherry, 5% of the strains were wild type against trimethoprim sulfamethoxazole. But the wild type 5% were still in exactly the same position that the 95% wild type in my area were positioned themselves. And the same for Haemophilus influenza and penicillin, et cetera, et cetera. So the wild type is a wild type is a wild type. Doesn't matter where we collect it. It's identifiable by statistics. It's identifiable by genetics. It's identifiable by phenotypic methods. And it's very important to know where normal is, where the wild type is, because if we as a committee are going to discuss what is abnormal, namely what has resistance and to what level, we are dead in the water if we haven't first defined the normal. And that becomes especially important when you realize that the MIC is not an absolute value, it's a relative value. And then if you do not have the relative normal to compare with, you will lose your footing.
There are two more questions online. One question is from Dr. Kalyani, and she asks, can you please elaborate a bit on the methodology of Vitek? Because in India, we use it everywhere and have stopped using this diffusion in favor of Vitek MICs.
Oh, that's a pity. That is a pity. I had a Vitek, but I threw it out because it just didn't do the job for me. So I thought a Phoenix would maybe be better. So I got a Phoenix and I used that for a year. And then I decided that it couldn't do the job either. So in my book, neither of the commercially available semi-automated systems can do the job properly. Whereas with frequent discussions inside of UCAST, we are all agreed that the most robust, most versatile, most flexible method is actually disk diffusion. You have to put a little bit of effort into organizing your staff and educating them. You have to put some effort into quality control, but you have to do that with Viteks and Phoenixes as well. But once you have learnt the trick, nothing beats disk diffusion, also from the point of view that whenever there is a new agent, this diffusion is immediately there to serve you, whereas for Vitex and Phoenixes and what have you not, you will have to wait and wait and wait until they have developed the appropriate methods. Also, the Vitek methodology is basically based on 2 concentrations and then an algorithm where you statistically, mathematically try to portray a concentration curve. So you try to calculate an MIC from 2 concentration points, if you like. Quite frankly, that methodology and that algorithm is performed from a very few species, and then it is assumed that the regression between MIC and the phenotypic output is the same for other species, and it is not always the case. So I'm very reluctant to use those 2 machines, which is not to say that there might not be a new machine coming along from some of those companies that are now developing new technologies. The problem right now is that they can normally not afford to go the full Monty. They can afford to go to proof of concept. They can afford to do eco like Klebsiella pneumonia, maybe Pseudomonas aeruginosa, but some balk at that because it becomes difficult. They will not do Haemophilus influenza. They will not do Streptococcus pneumonia. So you get a very limited test out of them. And therefore, they're often portrayed as rapid machines for positive blood cultures, because positive blood cultures are normally with the E. coli and Staph aureus and Klebsiella pneumonia, et cetera, et cetera. So they can then take a shortcut and they don't have to develop the rest. But with this diffusion, you actually have the full panel for all the agents, with very, very few exceptions, namely vancomycin for Staph aureus and colistin for anything, because the molecules will not diffuse. So,
One
Kalyan?
last question from Dr. Raksha Bhatt. She says, Professor, thank you for the wonderful talk. Can you please share some light on testing of the newer beta-lactamase inhibitors available for therapy for MDR strains? What is UCAS take on this? Because we have a lot of requests on the use of ceftazidime, avibactam with Astronam, etc. on the testing, and there's no real directive that we are aware of. It's just papers. So how would the UCAS take that forward?
All of those that you mentioned, ceftazidime, avibactam, ceftolozane, tazobactam, cefiderocol, imipenem, relebactam, meropenem, vaborbactam, and some of the newer that were on a list which have not hit the market yet. All of those have methodologies inside the UCAS webpage. So there are breakpoints in the tables for all of those I mentioned, and there are methods and MIC zone diameter correlations and MIC distributions for all of those available on the UCAS website.
What about the addition of Astronam for an OXA48 and NDM producer?
Yes, that's something which the world is discussing, and the discussion hasn't reached a point where we are in sufficient agreement yet to actually publish a recommendation for what we think should be done. But Astronam avibactam is being dealt with at the moment and discussed in the steering committee, and I will assume that we will reach a decision within the next 6 to 12 months.
Thank you, Professor, for that wonderful talk and for answering our questions. And I will transfer more questions along as they come.
Yes, just send them my email and I'll try to answer the questions. And thank you for having me. We've had a hot spell here. So 30 degrees, 35 degrees has been every day for the last 3 or 4 weeks. My roses are drooping. My dogs are panting. So we're hoping for some rain and cold weather now. Thank you for having me today and enjoy the rest of your conference. Thank you.
Thank you, Professor, from 42 degrees probably here in India. So we'll move on to the next session. We now request Professor Dr. Subhash Todi, Director of Emergency Medicine and Critical Care Medicine at Emory Hospitals, Kolkata, to talk on AMS in hospitals, barriers and opportunities.
Thank you all. Thanks for coming and thanks Dr. Sadhana, Dr. Jain for inviting me. So this is the task given to me. There are many barriers and many opportunities, but I am taking only 5 barriers and 5 opportunities, and I will restrict my talk to the hospital setting. You know, this subject of stewardship is very broad. It can go to the OPD setting. I'm not going to discuss about that. I'm not going to discuss about the One Health, the animal use and the agriculture use of antibiotics. So I will restrict myself to the hospital setting, and that also of hospitals of sort of the hospital here, like a secondary tertiary care hospitals, because in India is such a heterogeneous healthcare delivery system. So different type of settings might have a different approach. So we'll discuss about secondary tertiary care hospitals. So 5 barriers. So the first barrier of antimicrobial stewardship is a top administrators buy-in. We had a CEO. I was so glad to see CEO in this meeting, and that is what is needed. But we really need not the lip service, but we need to walk the talk. And when we say top administrator, we really mean very top administrators. We need the head of the state. Like this was the antibiotic stewardship declaration from White House by Barack Obama himself in 2014. And that led to this, development of, at that point of time, there was no new antibiotic for 10 years. And we were all facing a lot of problems of antibiotics. So new 10 antibiotics by 2020. And that led to the development of these antibiotics. But unfortunately, most of them do not address the problems that we are facing in India. You see, they are like imipenem, relibactam, meropenem, avibactam. They won't cover an NDM. They are for KPCs. Ornidavancin, dalavancin is a long-acting Staph aureus. So those are the problems in the West. And that is where the problem lies. But they have addressed their problem, and they have developed this newer antibiotics, though not a much new class of antibiotics, but these are the newer armamentarium, and they have developed it very fast over the last few years. The second, I would say from the top, it has come the Israel. In Israel, there was an outbreak of Klebsiella in 2007. And what they did was, on a war footing, they augmented information technology, microbiology, capacity, infection prevention, resources. And within 5 years, they were able to reduce their infection rate by 50%. Yes, we are a much bigger country than Israel, but at least our one state is as big as Israel. So I think they have shown a way to the world that, yes, it is possible by a concerted federal effort to reduce infection and do antibiotic stewardship. We in India have also played some role. We have an action plan, as Dr. Sardana mentioned, And at the present moment, we have not seen so much of a dent in outcome measures. When you measure outcome of this kind of a program, we haven't seen much dent, but I think we probably have to wait for it. So those were the national initiative. But when you come to the hospital per se, what is the hospital's response? What is called the C-suite. C-suite is, as you know, the C, Chief Executive Officer, the Chief Operating Officer, the Chief Financial Officer, everything which starts with C, they have to be involved. So this was one of the checklists, which also involved some of the Indian experts. This was a global hospital antimicrobial stewardship program. And their first item was, has your hospital management formally identified antimicrobial stewardship as a priority objective for the institution and included it in the key performance indicators? So I think that becomes a very, very important thing. So that the top people are involved and they have a commitment for this. We have a policy document from ICMR, but they go more into the processes. They haven't told us about how to get the administrators involved into this. Now, what are the administrators, basically the top administrators are interested in? They are interested in return of investment, revenue generation. I will discuss it in my second barrier, but they are interested in branding, marketing of the hospital. What are the insurance companies saying? The media, because they are very averse to any media if the publicity goes against the hospital. The accrediting agencies, the regulatory bodies, and the judiciaries. The social responsibility and the corporate governance, they are lip services. But I think the above things are very important for the top CEOs of the hospital. This is one which was built up by my librarian. And I have never seen a hoarding like this. They have put hoardings for robotic surgery and so many. I have never seen a hoarding which says, we prescribe less antibiotics, come to our hospital. I've never seen that. So I think this is what we should be looking for. And the media is also rising, and the rise of superbugs. When it comes into the media, the lay people reads it. And that is where you can have the attention of the top administrators. So that is the top administrators buy-in. How do we get to the top administrators? The second is the budgetary allocation. That's also very, very important. This is the second barrier. How much budget has been allocated to AIM stewardship program? Because at the end of the day, if you go to a corporate hospital, that is what they understand. They understand money. And that is, show me the money. So what can we do to talk to the administrators and put a business case to them? You see, we can tell them that, look, it decreases length of stay, it decreases resistance, it decreases mortality, but they look at this problem in a different way. They would say that, okay, it requires some fund, but that fund has to come from some other program. And that is where the problem lies. They have to sacrifice some other programs, and that is where the business plan has to stand. So this is something, when we say the length of stay, you see, it says that most of the hospital have a fixed cost. They have a cost of nurses, they have a fixed salary for the doctors. So if we say that we decrease the length of stay, and if the beds are vacant, they are still paying the salaries of all this staff. So basically, it will be a naive proposal to say that, look, this will decrease the length of stay, because that is not going to appeal to the CEOs. So how to do a business plan? The business plan in our country will depend upon where we are working. Like this hospital is a trust hospital, not for profit hospital. It will have a different business plan. We have to propose it differently. You see, the scheme patients, the corporate patient, the patients where there is a package, there it will work better. On the other hand, if it is a self-paid patient, the more the patient stays, the more is the medicines given to the patient, the more the revenue generation for the hospital. So that is why I think it is very important the business plan has to be such that we have to put it in a way that if we, the more and more scheme and packages patient are coming to the hospital, and that is the appeal to the administrators, that if we can decrease the cost of care of these patients, the additional revenue goes to the hospital. The pharmacy revenue also is like that. So I think it's very important the budgetary provision needs to be looked into that. The third barrier are dedicated personnel. When I look at the antimicrobial stewardship team, I see a lot of members, they are doing something else as well. AMS is a part of their other duties. Like, for example, our infectious disease consultant will have spent some time, probably in a day, on AMS, even the infection control nurse. So there are no dedicated personnel for this stewardship program. So how much do we need? There have been some studies, not from India, but from the West, which says that, this term full-time equivalent. Yes, we might not have a person full-time dedicated to AMS, but full-time equivalent is at least 9 to 5. They have 8 hours work. So we have to have people who can devote 8 hours. So if you have 4 hours, so 2 people devoting 4 hours each. So FTE 1 per 100 occupied beds. So that was what is the equation it came out to be. And 70% of the time they will be spending on patient care, that is doing the stewardship thing, and 30% on program management. Each 0.5 increase in pharmacist and physician full-time equivalent predicts a 1.48-fold increase in the odds of demonstrating effectiveness. So I think whenever we talk about the personnel involved in AMS, this full-time equivalent to bed ratio becomes a very important concept. We need to see how many beds we are covering, and then we have to get to how many people we need. The fourth barrier is having a trained personnel. Not only having persons, but are they trained for antimicrobial stewardship? This policy document says that we require an ID physician, clinician, clinical pharmacist, clinical microbiologist, and an infection control personnel. This was a study done from PGI, Chandigarh. This was a review article where they have mentioned, pharmacologist, you can even have surgeon, administrator, infection control personnel. And what they have written in there is that several studies have shown that these roles are not sacrosanct. And various professionals with adequate expertise and motivation can be trained optimally to perform AMS activities. It's been demonstrated that a trained nurse take on the role of pharmacist, whereas another group employ pharmacy residents and students. So basically, in a resource limited countries, it is very difficult to get trained ID personnel, trained clinical pharmacists, trained clinical microbiologists. So there has to be alternative pathways till we have enough workforce, which might take a decade or so, to train the alternative pathways in order to have this kind of an AMS workforce. So this inadequate doctor-patient in the developing world, and often the lack of interest and availability of ID physician, clinical pharmacologists is poised to expand if AMS endeavors are to be successful. So you see, this is a big group which probably need to grow if AMS has to be successful. So we need to train more and more clinical pharmacologists. And last barrier is non-availability of electronic health record. The AMS came into its being in the West because of electronic health record. About 80 to 90% of the hospitals in the West have EHR. It is mandatory. It's no more optional to get a license. But in our country, probably 10% will electronic health record. The life becomes very easy. If you have electronic health record, you know which patient is getting which antibiotic, why it is being prescribed, how many days it has been prescribed. There have been a lot of studies looking at the benefits. Even in countries like Cambodia, they have found that using electronic health record and artificial intelligence, they have found that it is very useful and improved susceptibility of gram-negative bacteria, including Pseudomonas, following implementation of a computerized antibiotic decision support system. So this CDSS system, the electronic health record, I think is a very important way forward. And at the present moment, I see it as a barrier. So these are the 5 big barriers which I perceive for AMS. Now, what are the opportunities? You know, we talked about barriers, but what are the opportunities? Now, the first opportunity is large at-risk population. Though some thinks it as a barrier, but I would assume that it is an opportunity. We have a lot of at-risk population where we can do work on and implement antimicrobial stewardship. We have surpassed China, as you all know, in population. And has been shown that we will have the largest population of antimicrobial resistance in the world. And there will be a lot of mortality. The mortality with antimicrobial resistance will be very, very high by 2020, 2030. And has been declared by the WHO, these are the different resistance bacteria. And we are almost heading the world on this. E. coli resistant to carbapenems, Klebsiella resistant to carbapenems, Finito resistant to carbapenems. So CREs and these are very rampant in our country. So very big population at risk. And so we have a big role to play. So this is an opportunity for us to practice AMS so that we can reduce this resistance burden. The second is the large antibiotic consumption. So not only we have a lot of antibiotic resistance, but we have very large antibiotic consumption. This was a study by Dr. Lakshmi Narayan and others who looked at the longitudinal use of consumption. And you see, India is the highest almost antibiotic consumption when you look at the resource limited countries. So again, I think this is an opportunity for AMS teams to decrease the antibiotic consumption. We each can individually contribute to it, but I think as a whole, I take it as an opportunity to decrease the antibiotic consumption. The third opportunity, I think, is this antibiotic. We have a lot of new antibiotics. We have old antibiotics we are using. And we have this antibiotic consumption. As was mentioned, we have so many new antibiotics which have been approved in the West. Some of them have been FDA approval, but they are not still available, many of them in our country. And can we have what is called emergency use authorization of this? Because you see, the antibiotics have to go through very rigorous regulatory requirements. But if we have these antibiotics already approved, can we get these in our country as an emergency use authorization? That becomes a very important antibiotic stewardship program. Now, these are the various combinations which is very unique to our country. It's not available anywhere in the world. Meropenem, sulbactam, EDT. But to be realistic and to be honest, our bacteria's resistance pattern need this kind of a combination. But we do not know whether they work, they do not work. So I think that this is an opportunity. We cannot throw these away because our bacterial resistance patterns are such. We have OXA, NDM, ESBL, all in one bacteria. So what to do? So I think it is very important. We are fortunate, I would say, in the West to get these through regulatory authorities would be a nightmare. But in our country, we have access to this, but to judiciously use it, I think will be a challenge to the antibiotic stewardship team. We have this combination generic drugs. The PK/PD of this combination, we are not very sure what is the clinical efficacy and what should be the optimal use of these drugs. And then we have these very old drugs, which are now used very commonly. Phosphomycin, colistin, minocycline, we have doxy, chloramphenicol. So again, an opportunity for antibiotic stewardship team to know how to optimally use these old drugs. So I think this is another area of use of antibiotics by the stewardship team, how to optimally utilize these antibiotics. So where to use, when to use, whether we should be using combination or not. Now this fourth is, we are very fortunate in our country to get availability of rapid diagnostics. I think even in the secondary care cities, we do get in the referral labs rapid diagnostics. It is available, and I think this is the way forward for antimicrobial stewardship. So availability of these, whether it is for fungal antigens, whether it is, we also have this whole genome sequencing. NGS will soon be available, and the prices are gradually going down. We have the antimicrobial resistance pattern. We also have this BioFire. At the present moment, they are expensive, but over time, the other companies are also coming up. So the diagnostic stewardship, you see, antimicrobial stewardship cannot move forward without having a diagnostic stewardship. And that is where these rapid diagnostic tools will play a very big role. I think it's very important that the antimicrobial stewardship team should be well versed with this. And I find it an opportunity in our country because we have access to these diagnostic tools and how to utilize this optimally. And last opportunity, as we have been mentioning all throughout the day, we are very fortunate and we are very passionate on this aspect, education, training, not much on research, but at least on education and training, we are very passionate and a lot of work has been done. And this is something that we need to follow. This is a new way of looking at antimicrobial stewardship. Is the previous, how to rank the antibiotics. Is colistin and ceftazidime, maybe bacterium, which one is higher, which one is lower, and so on. Because we need to have some kind of conceptual framework and practical framework of knowing how do we utilize the antibiotic stewardship. And this is a new article. That is what they are doing. They have divided into spectrum of activity. And this is how they are denoting the susceptibilities within each spectrum. Is it narrow, intermediate, broad, last resort? Is it susceptible to all or is it resistant to all? And so forth. And that is where they are ranking. Most desirable to the least desirable, slight overtreatment, severe overtreatment. And this is how you have to put the antibiotic that has been used into one of these boxes, and that will tell you where we are. And that is where the antibiotic stewardship team needs to practice. So which I think is an opportunity for us to use this kind of a doormat system and start utilizing antibiotic stewardship concepts. For research, our young infectious disease consultants are now, though this is an observational study, but the first study to look at ceftazidime with aztreonam, a question which was asked versus polymyxin. Many centers still use polymyxin. Many centers use ceftazidime versus aztreonam. Which one is better? So they have done an observation. It's difficult to do a randomized controlled trial with these kind of problems. And at least they have told us what would be the distribution, which is not very surprising from a corporate hospital to have this kind of a distribution of the bugs. And they have found that ceftazidime-based therapy was less likely to be associated with 28-day mortality. So as has been said that the BL-BLI combinations are somewhat better than the polymyxin-based therapy in this kind of population. As I was mentioning to Professor Mathai, this was again a big important research. You see, this milestone research, I would say, in antibiotic, in tropical infections coming out from Velour group, and which was published in NEGM. And these kind of research tells us that it is possible to do RCTs in our country with the problems that we face. And it is accepted by the world because this is a problem which is being now recognized in many other parts of the world. So these are the different training courses. This is from ISCCM, and Dr. Sardana has mentioned a lot of training modules and courses that has been run by HSI. So education, training, and research is another opportunity. So the 5 barriers that I talked about was top administrators buy-in. I think this hospital is very fortunate, but we need to get not the middle administrator, we need to go to the top administrations buy-in. A finite amount of budget has to be allocated for the AMS program. It has to be written down. There has to be an annual budget. There has to be dedicated personnel, not people who are flitting around the hospital and just does some work for AMS. We require more trained personnel and electronic health record. I think that is something we really need for AMS to pick up. The opportunities, the population we have, the large antibiotic consumption that we have, the different kinds of antibiotics we have, access to rapid diagnostics, and education, research, training. So I think the barriers and opportunities are there. You can think of something else as well. I think the way forward would be to look at these opportunities and be aware of the barriers and get over it. Thank you very much for your patient listening.
Hello, thank you, sir. If there are any questions from the audience, we can. Yes.
Comments and questions.
I always believe in good compliments. I don't believe in criticism. So I'm very honored, sir, to see you after so many years. 15
Same
years
here.
back, I worked with you in AMRI Kolkata. And I remember when nobody even knew about procalcitonin and NT-proBNP, you used to advise it, and we had to get all those records documented before you in the morning rounds. So I'm so happy and overwhelmed. And I think your entire approach to antimicrobial stewardship was very different. So I think it will enable us to calm down our focus. And if we can cross these barriers, I think that itself will be a long way. So thank you so much.
Thank you. This was more of an administrative talk, I must say. I haven't gone into the processes and all, which are very well defined. But these are the things which needs to be implemented for the AMS to pick up in our country.
And I now request Dr. Shubha to please present a bouquet and a small memento as a token of gratitude to Dr. Todi. And we are really thankful for you to have made time to come and spend this afternoon with us and enlighten us with your wisdom. Before we continue on the session, I also request Dr. T.S. Jain to please receive a memento from Dr. Krupa. Thank you so much for helping us launch this event, and we hope we will be able to see through the dreams. Please come. Go on the stage. Yeah, then picture with. Thank you. I now request Dr. Dilip Patai, if you can please present Professor Sardana with Professor Raman Sardana. Can you please accept this small token of gratitude? Sir.
On behalf of all of you, it's an honor to receive anything from sir.
Sir, can you also stay on stage, Dilip Patai, sir? Sir, please stay on stage. Can I request Dr. Uma Shekhar to please accept a token of gratitude from, yeah, but thank you for coming. Thank you. We'll now go on to the next session. Dr. Srividya is going to tell us about challenges in infection control. She's going to share her experience with us. And following that, we will have a case presentation and a few questions that we will answer with the panelists.
Excuse me. So you're leaving, not even hearing to me. Maybe 5 minutes? Yeah. So I am Dr. Srividya. I touch this holy dais and promise that I'll keep you alert, awake, and cheerful for the next 15 minutes. So this is what infection control challenges are. People want us to be blindfolded, but we don't want to be. We want to be wide awake, alert, but always it's not possible. So we land up being this, like a pirate. We tend to overlook sometimes. We tend to see openly sometimes. And sometimes people make us shut our eyes, but we are like, no, we're going to be awake. It's a big challenge. So this is yet another challenge. So every hospital should have a proper organogram in place. So organogram, not just for audits, it's not just for documentation. It has to be physically active. So if the unit head or the operational head, the medical admin with the ID and the microbiologist and everybody put together, I think if all of us do our part well, so I think which has been reiterated several times today, everything will actually fall in place and we should have one common goal: no infection or less infection, prevention of infection, ultimately good clinical outcome, patient safety. So these are the mundane barriers. The first mundane barrier is get up in the morning at 4:45, wind up all your kitchen activities, take care of your children, then go to hospital, right? And then when your clock strikes 8, you should be alert. You should do your reporting in the lab, being a clinical microbiologist. At the same time, you talk to the ICN, get things coordinated. So at every step, there is a challenge. I'm being practical. I'm like, and you know what we actually undergo on a day-to-day basis. So infrastructural issues always be there. So if you want to do something really nice, there'll be 20 obstacles. So if there are 20 obstacles, that means you're in the right path. So this is what I learned. Behavioral. Everybody has an attitude problem. You tell something, either they shut their ears, shut their eyes and walk away. They are still okay. There are some who will hear to you, but they will not react. They will not respond. They are the most difficult people to handle. And there'll be one who will do both. They will listen to you, they will hear to you, and they will react and they will respond. So we are looking for good responses, not reactions. Organizational. So some of us are lucky. I'm lucky that I'm part of Apollo. So we have certain things in place. Of course, streamlining at bigger corporates also is not so easy. But what about those hospitals where the infection control team really wants to do a lot, but they don't get a lot of support from the organization? Obviously, motivational. You keep telling 15 times, 20 times, things don't happen, nothing changes, so you change yourself. So you give up, you stop telling them what to do. So we have this motivational barrier too. Obviously, resources. You know, when we have audits, they'll tell you 1% goes for the infection control. You're like, where is that 1%? When did you give it to me? So these are challenges we face almost every day. So I think we should have a positive attitude to help bridge all these gaps. We have a lot of dreams, but we have to work on those dreams to bring things aligned. So the voice has to reach and be heard. You know, when we have these HICC meetings, these meetings are held NABH, thanks to NABH. Okay, sometimes they'll say meet once in 3 months. Then they'll say meet once in 2 months. Then they say meet once every month. So the more often we meet, there are very few people who will bring things onto the table. They discuss things once the meeting is over, so that their voice is actually not heard. So the right thing is to get things sorted out on the table. Talking behind people or talking behind the management or the admin really doesn't help. So who will bell the cat? So this is a very important challenge which we see at our hospital. See, when it comes to surgeons, we all know how they act, how they react, how they respond. So when we talk to them, obviously it is called, a very handshake kind of a friendly atmosphere we have to build with them. So rapport building is our first challenge. We know that most of the people have their antibiotic choice or the incision time for the antibiotics in place, but this is the main area of challenge, stoppage of antibiotics. Because each person has his or her own protocol, although you would have set up a list of guidelines for them. So what you see is last year data I tried to compile, we've not even reached the 60% or 70% mark. And I was very honest with the data, because 100 is a very realistic number and it's unachievable, at least not in the next 5-6 years. So the list is long. So you have a list of quality monitors, no? So whenever you have to document, you have to first choose what are the things you will actually monitor. Choosing itself is quite difficult. SSIs, one more area of a lot of challenge. Whether your equipments have been sterile, whether surgeon has scrubbed properly, how the environmental surveillance has been of the hospital. Everything is accountable. Prescription monitoring. Again, handling people's egos are also a big challenge. So IP prescription monitoring with the help of the pharmacist, we can at least get it done. But when it comes to OP, it's a big challenge. So again, rapport building with the clinical pharmacist. So you have to act as if everybody is good in your workplace. Only then things happen right. So when you want to educate them about your DDD, the data required, you need to actually teach them and then get certain things back in return. Notifiable diseases is another area of challenge, because again, when it comes to IP, I at least with the micro lab or the ICN, the news reaches the MRD tells the corporation. But in the OP areas, what we've seen is many cases are missed, especially a lot of cases in TB, dengue, they're all missed. Care of care bundles. So in many places, they have hybrid data. Some say it's online, some say it's offline. There's a lot of confusion. And when you actually train nurses to take care of the care bundles, you see they leave and go. So I think the attrition rate of nurses also is a big challenge. Then vaccination. I think counseling people, especially healthcare workers also during the COVID time was very tough. So only then we could actually go into the community. So that is an area of challenge. The FNB, you tell the people that you need to get vaccinated. You need to give your stool for examination. They refuse because they don't know that it's so important. Dialysis unit is yet another unit of challenge, because they don't want to be open about many of their data or many of the deviations which go wrong on a day-to-day basis. Yes, the list is getting longer. So hospital-acquired infections are again a challenge. You have a lot of cases you need to isolate, but you only have 2 isolation rooms. You don't even know whether it's a negative pressure room or not. So everything is a challenge. Whenever there's an outbreak, whether you should talk about the outbreak, that it's a challenge. How do you investigate the outbreak? That again is another challenge. Then these biomedical waste management. So when we go to these outsourced sites, they tell us we work during the night, but we visit them during the day. So that itself is a challenge. the laundry. We outsource it to a bigger organization here. But what we realized is during COVID time, they had a lot of things in place. The segregation was fine. But now when we revisit them, everything has disappeared. I don't know how it happened. I think it's like a Rajnikant movie, because one day you go, it's there. The next day it's not there. That's a challenge. Risk assessment in infection control is again a challenge, because risk assessment is an area where all of us are learning, including laboratory medicine as well as infection control. Managing visitors is a challenge. So whenever the management has an issue telling people something, they will look for the infection control officer or the ICN. So whenever people look for you, don't always be happy. It means there's a problem underlying. So when they call you, it means there's something wrong. So they'll put you in the front. But then you have to be courageous and talk to the people. Single-use devices, CSSD, all this is a challenge, because you tell them these are the 7 SUDs. Suddenly you'll be using 12 more. You'll not be aware. Then one fine day when the audit happens, they tell about all those 12 to the auditor, and they put all of us in trouble. So that is a challenge. We need a very good ICN. Getting a very good ICN, I think it's like getting a topping on the cake. So we have a good ICN at Apollo, and a good nursing support to the ICN, because the ICN will need linked nurses. She'll need hand hygiene champions. So if all that is in place, then your challenge is a little lesser. So why I showed this hand hygiene form is gathering this form itself is a challenge. It has so many points. You have to note down everything, right? So, and you have to be impartial. So this entire tool of hand hygiene is a challenge. Another thing is, even when you try to train people or you try to retrain people, you can never achieve the 100% compliance for hand hygiene. Again, if you say it's 100, it's not true. And then when it's not 100, the management will not like it, because the auditor will say, why is it not 100? Then if you put it as 100, the auditor says, how is it 100? So you really don't know what to do. You're in a dilemma. So that's a challenge. So we were very happy to see that doctors were at least 90% compliant. Nurses, obviously at par with doctors, if not better. This is the category where we always have challenges. The front office people, who are the people who don't want to understand a lot of things. So gathering all this data, every time we gather data, people want data designed in a different fashion. That again is a challenge. So we started this last year, because before that we didn't have the data for this. So all the 5 hand hygiene moments monitoring. So obviously it's not just what we talk, it is what we do. So when you have this antimicrobial resistance increasing, as Sir just mentioned before this, you have this AMSP, and you really don't have dedicated personnel, because people love people who multitask, okay? And obviously microbiology inputs is a challenge, because in many places the microbiologists will know a lot of things, but again, they're scared. Like, what if they raise their voice? Will that voice be heard or not? So that is a challenge. So every institute should have at least a local antibiogram. The challenge is, don't copy paste somebody else's antibiogram and cook it up. Prepare your own. So that is the challenge. So in our hospital, we monitor this high-end forms, and it took us quite a long time for people to actually fill the forms. Previously, we used to get forms, but all were unfilled. So everything, again, is a challenge. This is just to show the trends. So does this trend make too much of a difference to people? Does it make too much of a difference to the common man? Yes, it does. He or she may not know anything about the healthcare system, but when we all know that AMR is a community issue. Needle stick injury is yet another challenge. There are very few people who will actually come and tell you that they had a needle stick injury. So that is a challenge. So they're scared, they're petrified, because people don't generally talk about these things. They only talk about it when the problem actually happens. That time they're looking for the protocols here and there, where to go, what to do. So when you have regular training programs on these issues, then your challenge is lessened. So we did a fishbone analysis a couple of times, because needle stick injury, we've had a lot of cases every year. So obviously it was because of carelessness. People were not adhering to safety precautions, or you train a person with great difficulty, whether it's the HK staff or the nurse, and they all happily leave by 6 months. This is a big challenge. So people only know that a microbiologist exists when we give results as unsatisfactory. Till then, people feel, oh, there's nobody. So that is the challenge. When you say that there is a problem in the HEPA filter, there's a problem in your OT, there's a problem in the cath lab, the endotoxin levels are not fine. So the moment you start telling them, then you're like the talk of the town. Okay, they know, oh, somebody called Dr. Shividya exists. So that is again, building up that loop, escalating it to the management, getting it sorted. That is the challenge. The challenge doesn't lie only in talking amongst the staff or the other doctors. We have to get the problem sorted. So satisfactory is a very, very tricky word here. Okay. So training and awareness, that itself is a challenge. You call for classes, 10 people will come because the HOD will push the same 10 people every month. The rest 20 will not come, and those 20 are the ones who will not understand the normal norms of HIC. Obviously, prospective audits and feedbacks are a challenge. So only if the ICN and the micro lab work together as a team in collaboration, many of these challenges can be lessened. Any guesses who this king is? You all should revise your mythology then. This is Raja Harish Chandra. Okay. So we cannot be Raja Harish Chandra. We cannot be 100% truthful at all points of time. I'm talking about the infection control team as per se. But we really have to be daring. Unless we talk the truth, we discuss the truth. Truth is always not palatable, but truth will definitely get us a long way. So this is the herringbone. I love this PPT a lot because this shows that every challenge can be overcome if all of us work together as a team 24/7. So if all of us work together as a team, unity is always strength. So people will obviously understand what the difficulties we are facing, and we can have a much better approach to the HIC. So I am blessed to be a part of a good team. So that is my microbiology lab team. And this is the HIC team. So we have Dr. Nambi here. I saw Dr. Suresh also sitting here. We worked together when we were of the same cluster in Karapakam. This is Kavita. She looks very fragile, but she's a very dynamic ICN. So we have miles to travel and smiles to spread. So thank you so much. What we feel is every challenge should have the right mindset so that we can overcome it, and challenges will be there. As long as challenges are there, our jobs are secure. Thank you.
Fantastic session. Thank you so much. Any questions?
Great talk. Since you have asked me to stay on, I need to ask a couple of questions. When we go through every month, the VAP rate, the CRBSI rate, the UTI rate, it's very minimal. But most of my VAP ventilator patients are on antibiotics. So why are they on antibiotics if the VAP rate is so low, the UTI rate is low? 60–70% of my patients after 48 hours on new antibiotics. So how do you go about addressing this problem?
This problem is a problem for us also, sir. So that's the best way of answering you, because we've also not picked up any VAPs. We tried collecting it as VAEs also.
Yes.
Okay. But then when we wanted to do the VAEs, again, we didn't know what to fit in and what not to fit in. So even when we have documented VAPs also, we've hardly got any VAPs. A couple of them existed during the COVID time. We had a lot of acinetos and all at that
But
point
how
of
many
time.
patients were on antibiotics? On ventilator?
Almost all of them.
So how come they don't
No,
have VAPs?
no, that was a dilemma. But
You
when
see-
we tried to do the data workup, we couldn't document it as a VAP.
I will tell you the way we go about it is, I want to ask them after 48 hours, each culture which was positive from ET suction, they have to have an explanation why this was not termed as VAP. They have to tell me that there was no lung infiltrate, no antibiotic given. Something has to be explained against each culture positive after 48 hours, which was sent. Then only I'm convinced that there is no VAP. When you start doing that, you see so many missed VAPs. You see, on word round, nobody diagnosed it as VAP, but antibiotic was given. So explain to me, why was this culture positive and no antibiotic why was antibiotic given to this patient? So I think that is very important. The same is with central line, the same is with urinary tract. So you have to divide the cultures into A and B. A is on admission, B is
And
after
48
48
hours.
hours.
Yeah.
After 48 hours culture needs some explanation. So that is the way we do it every month. And we do find out a lot of gaps which were missed in the initial analysis.
We
The,
do
the
that.
second question is this hand hygiene. 80-90% compliance with hand hygiene. And we think hand hygiene is the biggest issue which causes infection. So if we have a 90% compliance with hand hygiene, which almost all the corporate hospitals, the big
Have.
hospitals will show 90% compliance.
We've actually shown less, they show 100.
100. So why is so much infection if we have so much of hand hygiene compliance? So that is the issue with hand hygiene compliance recording.
So what I personally feel is, like when we document it, it is usually the ICN who does the hand hygiene audits in most of the places. So to be very honest, whether it's an unbiased audit or not, we do not know. So that is where we have pitched in people from the quality cell, even people from working in the dialysis in the front office. Like we've created some hand hygiene champions who have been trained on this hand hygiene, because we feel sometimes it has to be done random also, right? Usually hand hygiene audits are done random. So whether it's actually done random or not, that also is a challenge.
One of the best methods is by INIC, infection nosocomial by Dr. Rosen. He has a system where you see, like an ICU will have 20 nurses, will have 15 doctors. So you have to see each nurse doing the hand hygiene, right? It's not possible to see each nurse having hand hygiene. So you have to identify one nurse. And if that nurse knows that somebody is looking at the hand hygiene, he or she will perform very well. So you have to identify a person who will not tell that nurse that she is being looked at. So every day you change the nurses, every day you change the doctor who's been looked at, and shift. You see, the night shift is, 12-hour shift, and somebody has to. So the shift in charge has to see the nurse and the doctor, and that has to be documented. There is a table of that, and he has one of the best ways to look at the hand hygiene compliance in the ICU without being observed, and to look with each. You'll find that we started doing it about 15 years back. There is a group of nurses and group of doctors. They regularly failed hand hygiene, and quite a group did very well hand hygiene. These 80-90% usually miss that kind of a picture. So those group needs to be trained. So I think those needs to be looked into in a more detailed manner in order to get over these problems.
Sure.
Thank you.
As the Houghton effect, goes on, I have a couple of comments.
I think I'm the guinea
Thank
pig
you.
for the day.
Now, everybody keeps saying, like I told you, 40 years I've been practicing infection control. I've only created more MDR organisms. I have not brought it down. Fundamentally, when your child asks you for pocket money, how much money do you want, son? You will say, ice cream 1 rupee, one rupee per juice, etc. How much money do you want per bed? 150 rupees, shall I give you? Now you give me a breakdown of that 150 rupees. And I want guarantees. Would you give me guarantees? Microbiologist, infectious disease consultant, would you give me guarantee? I will give you money. Secondly, why can't you bill the patient? You say room charge 6,000 or 4,000. You say consultation fee 1,000. You say nursing charge 500. You say ICN charge infection control 150. If you go to a restaurant, you were all fighting for surcharge, 12% surcharge. Don't put it in my bill, no more surcharge. You tell them, brother, I did not give you an infection. Therefore, you are paying me 150. You pay me 150 per bed and give you an infection. Can you give money back guarantee? You have to think corporate. You have to think how the patient wants. No, you can't do this. Keep on going and saying, give more money. Give and I was an administrator once. Now I am a working class hero. Okay. So what I'm trying to say is, I will not part with my money. If the guy wants to go and have drugs and cigarettes, I won't give it to my son. What would you do with that? You tell me, when I trained under, when, initially when I was University of Iowa, Dick Wenzel, he told me, Dilip, before you touch the patient, wash your hands. After you touch your patient, wash your hands. Then we have Didier from Switzerland. He has asked me to touch, before I touch my sphygmomanometer, wash my hand. After I finish with the sphygmomanometer, wash my hand. Now, how many times, how many times can I keep washing hand hygiene? Okay, so now the concepts you have to drill in to my medical students, to my nurses, etc. Hand hygiene is proven that you have to do. Before you start touching the patient, after you touching the patient. Not before you take dal curry and mutton curry. No, you have to have some separated. Second, why do you allow somebody to put in and touch the wound? It belongs to the surgeon. And if that surgeon has a gram-negative organism, catch him or her. But why do you, nothing to do with the ICN nurse. ICN nurse is, sorry, ICN nurse is not there when I peel open when I peel open. So surgeon will come and ask, is there any infection? No infection. How do you know? But he's still continuing antibiotic. These are the things that we have to stop. No, ma'am, I'm accepting that things have to change. Otherwise, you will continue in the same way. And so you must have some impactful decision making on this. I challenge the HIS to come out with a cost accounted statement for Ganasab. Can you give me a cost accounted statement of how much it costs per bed? I'm not talking about Apollo, I'm not talking about Triple M, but in general. Same thing should be translated to the government hospital, because you had also told about inter and intra-hospital transmission. So you have to look at some kind of a research and tell the administrators, I want this much money.
So thank you. I hope my guinea pig quota is over for the day.
Thank you. Thank you so much. We have a small video to show you. Again, this is from my nurses, and it was a really nice concept that was developed by Dorothy, Madam, our head of clinical governance. So this is hand hygiene for you from Triple M. Thank you. So we'll now go on to a small case presentation, and then the Dr. Arun and the panel discussion.
Good evening to one and all present here. It's an honor to be here, to be present. It's an honor to be here this evening to present a spectrum of cases that recently caught my attention. Before I move on to my narration, I would like to take this opportunity to thank the organizers for sharing this platform with me in front of such an esteemed delegates. Moving on to my case presentation. My case number 1 is a 30-year-old female who was lactating, had an LSCS 3 years back. The patient presented with complaints of swelling in the left breast, which was associated with pain. The swelling and the pain was on and off for the last 3 months prior to the presentation in the hospital. The pain and swelling gradually increased in intensity for 2 weeks, after which the patient had presented to the ER department. The patient also complained of intermittent fever. There was no history of any discharge from the nipple. No history of any loss of appetite or loss of weight. There was no history of contact with a known case of tuberculosis. With regards to past history, there's no past history of diabetes, hypertension, or any other illness of medical importance. No history of drug use or allergy. There was, of course, a family history of breast and uterine malignancy, which is present in the patient's mother. On examination, a fluctuant soft swelling of 3 by 3 centimeter was palpable in the central and subareolar region of the left breast. The mass was not fixed to the skin and the upper skin was warm and erythematous. It was tender to touch, and on deep compression, a seropurulent discharge was expressed from the nipple. No nipple retraction. The axilla was free of any palpable lymph nodes, and the rest of the systemic examination was unremarkable. Moving on to investigations, ultrasonogram of the left breast showed a heterogeneously hypoechoic collection measuring around 3 into 3 centimeter, which is suggestive of an abscess. The pus was drained by incision and drainage and sent to culture and sensitivity, AFB smear, and was sent for histopathology as well. Routine blood investigations were ordered, which showed mildly elevated total count and an elevated ESR. The 3H serology was negative. The histopathology came back as sheets of inflammatory cell infiltrate comprising of neutrophils, lymphocytes, and plasma cells with few capillaries and fibroblasts. Moving on to my case number 2. This is a 40-year-old male presented with a painful swelling in the right submandibular region. The swelling was first noticed 7 days prior to admission and was becoming progressively larger and more tender. There was history of intermittent fever, history of loss of appetite. The patient complained of severe nausea. There was also history of loss of weight. Past history, the patient was a known diabetic but was not on any treatment. No past history of hypertension, no history of drug use or allergy. The patient was not a smoker. And again, there was no history of contact with a known case of tuberculosis. On examination, he was febrile and a pulse of 90 beats per minute and blood pressure 130 by 70. There was a diffuse mass in the right submandibular region that was found to be tender and measured around 3 into 2 centimeter. A few painful lymph nodes were noted in the right cervical region. Investigations, his plasma blood glucose levels were elevated around 200. HbA1c was 11%, which showed poor glycemic control. CRP was again elevated 200. Elevated total counts, and ESR was also high. Chest radiograph was done and was found to be normal. CT scan of the neck along with USG screening was suggestive of an abscess. Right cervical exploration and drainage of the abscess was done under GA. The drained pus was sent for culture and sensitivity, and AB smear and TB PCR was also done. Case number 3 is a 24-year-old primigravida who presented at 16 weeks of gestation. The patient had a normal conception, non-consanguineous marriage. The patient presented with complaints of severe lower abdominal pain, slight bleeding per vaginum, intermittent fever, chills and headache for the last 2 days. No past history of diabetes, hypertension, or any other illness of medical importance. No history of drug use or allergy, and patient was not a smoker. On examination, the patient was febrile, conscious. Systemic examination was normal. A blood-stained, foul-smelling vaginal discharge was noted. Ultrasound showed a viable fetus, cervical incompetence, and oligohydramnios. Subsequently, after around 6 to 8 hours, a dead fetus was expelled spontaneously. A high vaginal swab and urine were sent for culture sensitivity. Torch panel was also evaluated for the patient. At this point, I would like to tell you that for all 3 case scenarios, it was a single organism that finally found as a causative agent. Moving on to the differential diagnosis, these are the possible agents that can cause a similar spectrum of diseases. Staphylococcus, as you all know, is one of the leading causes of breast abscess as well as the cervical abscess, and is also known to cause miscarriages. Streptococcal, both group A and group B streptococcus, tuberculosis, E. coli, Klebsiella, anaerobes such as Peptostreptococcus, Propionibacterium, Bacteroides, Clostridia, as well as Salmonella. The microbiological workup, moving on to the most important part, the AB smear and the TB PCR from both the abscesses were found to be negative. Torch evaluation for the 3rd patient was also negative. The specimen taken from the abscesses and the high vaginal swab were processed for gram stain. In all 3 cases, the gram stain revealed gram-negative bacilli and plenty of polymorphonuclear cells. The samples were plated onto 5% sheep lead agar and McConkey agar and then incubated. After 24 hours, the plate showed growth of non-lactose fermenting colonies on McConkey agar and moist non-hemolytic colonies on blood agar, further identified using an automated system. We have Phoenix M50, which was used to make an ID. So at this point, any of you want to take a guess on what this organism could be?
confused.
Yes, sir.
You have presented three patients.
Yes, sir. All three have the same.
All three have got the same organism.
Yes, sir.
And may I also say that nothing was grown from the bloodstream?
No, sir, no.
And the only one doubt I have, is it the submandibular lymph node or submandibular gland that was aspirated?
It was a pyomyositis, sir. It was a skeletal muscle abscess.
It was a muscle.
Muscle,
So
yes.
that was the anatomic structures of the infection. First one was in the breast tissue.
Yes, sir.
The second one was in the soft tissue.
Yes, sir.
And the third one was in the uterine cavity.
Yes, sir.
Perhaps, okay, let's say uterine cavity.
Yes,
Now, and three different patients
yes, sir.
hailing from which part?
Two patients from, were
Okay,
from Chennai
Now,
and.
because some of the
yes.
organisms that I might think of is brucella,
Okay, sir. Okay,
okay? Number one, I am not thinking of melioidosis,
okay, sir.
okay? The third one that I am thinking of is proper, because you have to look at three common ones.
Yes,
I might go for, since you have said it, and it's also showing non-lactose fermenters,
yes, sir.
which you've given us the clue as such,
Yes.
okay? So I don't know which way to go on this. Of course, the person has a systemic infection. I would go for these three first.
Okay, sir.
Brucella, melioidosis. Why brucella? Because lymph node is there or submat. And second one is melioidosis. I am not in favor of tuberculosis.
Yes.
But it could be.
Okay.
And fourth one, I'm not in favor of salmonella as such. Okay. But perhaps it is so. But blood cultures were all negative.
Blood cultures, I have not revealed it as of now, sir. But at that point, cultures were not sent. Only these cultures were sent
Then
at
I
that
will add
point.
salmonella.
Oxidase?
Oxidase was negative.
That is very interesting.
Yes. So
Any
yes,
more-
like sir said, okay, I've. So we did go on and isolate salmonella from all the three patients. The breast abscess and as well as the miscarriage, the high vaginal swab grew Salmonella typhi. Since this was at least rare for me in my laboratory, I cross-confirmed the identification on another platform as well. And then we went ahead and serotyped the isolated Salmonella typhi. But the neck abscess, we could not speciate it. We could only give it a Salmonella species. I could not find out what exactly it is, and I could not do serotyping for that neck abscess patient. And after discussion with the consultant, we went ahead and released the isolated Salmonella species. So it is all coming down to Salmonella. So case one, breast abscess due to Salmonella typhi. In the case sheet, it was clearly noted that the patient had history of typhoid 4 months prior to the first episode of breast abscess. On day one, she was started on injections Spasaf and Metrogel. This was before the culture report. On day two, the patient was afebrile and was discharged at request on tablets Ceftum 500 mg BD. After the culture report, the patient could not be reached and was lost to follow-up. The patient unfortunately returned 6 months later with another abscess in the left breast. Pus was again drained. This time the consultant spoke to me, so I had asked for blood cultures and stool cultures. Repeat isolation of Salmonella typhi was again done in the pus sample. This time the patient was initiated on injection ceftriaxone therapy for 2 weeks. And so far I think the patient is still under follow-up. This was it was around 10 days back. Literature review, Salmonella and breast abscess is an uncommon but a late complication of typhoid fever. According to Patel et al. In a paper published in the International Journal of Community Medicine, Salmonella as a causative agent of breast abscess occurs in about 0.9%. According to a paper published by Baron et al. In an article in BMC Infectious Disease, salmonellosis is thought to occur secondary to bacteremia and gastroenteritis, and patients with severe underlying conditions are known to be prone to focal infections. It is also hypothesized that patients' breasts might have become infected during a transient bacteremic episode originating from the patient's and immunosuppressive state of the patient facilitates the formation of abscess. Also, inappropriate or inadequate therapy of the underlying infection may cause dissemination to multiple organs and eventually lead to localized abscess formation. This was this is from an article that was published in PubMed Central, which reported around 16 to 17 cases of breast abscess due to Salmonella, out of which 14 were due to Salmonella typhi and 4 were due to paratyphi. The major risk factors are extremes of age, pregnancy, lactation, immunosuppression, underlying malignancy, IV drug abuse, and previous trauma. Through analyzing literature, it has been observed that most patients are immunocompetent non-lactating females. Any breast abscess in a female with or without a history of enteric fever and no other predisposing factors must be evaluated, keeping the possibility of Salmonella breast abscess. The pus aspirated should be sent for bacteriological analysis. If not done, such diagnosis can easily be missed. Moving on to my case number 2, which is a neck abscess due to Salmonella species. No significant past history of typhoid fever or fever with diarrhea could be elicited from the patient. Day 1, the patient was started on injection Advent 1.2 gram IVBD and Linnet 600 mg IVBD. Post-culture report, the patient was shifted to injection ceftriaxone 2 gram IVOD for a week. Blood and stool cultures were sent and were found to be sterile. The abscess showed complete resolution and has showed no recurrence so far. This again a small literature review. As a cause of neck abscess, Salmonella is extremely rare. Staph aureus, as we all know, is the most common causative cause for the bacterial pyomyositis. According to a paper published by Mina Pastegia in 2013, the most frequent locations of abscess have been the gluteus, the psoas, and the quadriceps. Location in the neck occurs in about 0.4%. Patients with systemic illness are predisposed to such focal infections. Soft tissue infections are again especially are caused by hematogenous or even lymphatic dissemination of the primary GI infection. The lymphatic spread of the Salmonella may occur directly via the lymphatic vessels from the GI tract or spread through the lymphatic vessels in the tonsillar tissue through the oropharynx. In our case, we could not exactly determine the direct mechanism of the infections in the blood and the stool. Cultures were negative. The bacterium itself can live for unknown periods of time in the macrophages, resulting in a continuous carrier state as well. As per literature review by Sue et al., out of 19 cases of neck abscess with soft tissue involvement by Salmonella, 15 were adults and 9 of those had diabetes as a predisposing factor. In immunocompromised patients, Salmonella must remain the differential for any muscle or neck abscess. These patients must be screened for diabetes mellitus and maintain strict glucose control. The recovery of Salmonella confers a high risk of mortality and appropriate treatment needs to be done along with surgical intervention. Case 3 is miscarriage due to Salmonella typhi. The patient had a history of fever with GI symptoms, a very vague history, 3 weeks prior to the presentation. Post the expulsion, the patient was started on injection zone and injection Metrogyl. Patient became afebrile within 24 hours and was discharged at request. No follow-up after the final culture. The patient was from Andhra Pradesh, so we could not reach the patient or call her back to the OP or call her back for a repeat consultation. So this was completely lost to follow-up. As per reports by Hicks and French, Salmonella typhi may cross placenta and cause miscarriage in around 65% of patients. It can cause stillbirths and preterm labor. Rare case of vertical transmission of Salmonella paratyphi A with severe complication and high mortality has been reported by Ravindran et al. Transplacental transmission usually presents at spontaneous second trimester abortion without premature rupture of membranes. Though salmonellosis usually is not included in the differential diagnosis of miscarriage, stillbirth, or neonatal sepsis that occurs during pregnancy, based on your local prevalence, it should be considered to prevent further fetal and mother morbidity and mortality. My take-home message is Salmonella is usually a true pathogen capable of causing both intestinal and extra-intestinal infection. These cases highlight the need for understanding the local epidemiology of enteric fever and its possible complications. Complete assessment of the patient, including imaging, microbiological culture, drug susceptibility, are essential for appropriate management of rare complications of enteric fever. Clinician must be aware of the management and make referrals, ID referrals, if and when possible for the patient. If resolution does not occur rapidly with a single course of antibiotic therapy, delay in such issues can have serious consequences on residual morbidity.
Very nice cases. Thank you, Dr. Kripa. Really enjoyed the presentation.
Yes.
Thank you. You have not speciated it.
One,
Is it Salmonella typhi or typhimurium?
it is typhi, sir.
Typhi.
Typhi.
All three of them.
2 were typhi, 1 we were not able to speciate.
Doesn't matter. Because I teach that Salmonella has to reside in some place. And the place it resides in is macrophage.
Yes, sir.
Where is the macrophage in my breast? Where is the macrophage in my pus, in my soft tissue or the muscle? Perhaps macrophages are there in the uterus. So very difficult to teach that this is Salmonella. I guessed it simply because you gave me the culture report, the cultural characteristics. Otherwise, I was thinking of a gram negative. I was not thinking of a gram-positive because nobody will put McConkey agar there. Okay. So, it's a guess because it is not my training to make a diagnosis of salmonella. Because I teach my medical students, you have to think in terms of salmonella because it has to reside in some place. Tuberculosis, macrophages, histoplasma, macrophages. Okay, number one. Number two, a short story. I was born of a typhoid mother. When my mother was carrying me 71 years ago, she had typhoid. And she was treated with chloramphenicol. You have not shown me the susceptibility pattern here.
So, yes, sir, I
Okay.
can.
I'm sure this organism will be susceptible to chloramphenicol, but
was.
nobody will use chloramphenicol. My mother was treated with chloramphenicol, and the only side effect I got was this white hair, gray baby syndrome as such. Thank you.
Thank you.
No, just one comment, and that was very well presented cases, in fact. So when we are writing something, especially from now onwards, maybe you don't write the commercial names of the drugs, especially antibiotics.
Noted, sir.
So zone and metrogel would be ceftriaxone and metronidazole.
Yes, sir, got it. Sure. Yes,
I'll
ma'am,
end.
yes, ma'am, noted, yes. Sir. Thank you so much, Dr. Kripa, and we'll now move on to the last but one penultimate session. Dr. Arun is from BD, and he has very happily been a part of our this whole event. He has helped us sponsor this event, so we'd like to thank him for it. And he would like to talk on middleware.
So good evening, everyone. I'd like to thank the organizers of Chennai Micromeet for supporting us and allowing us to be a part of Chennai Micromeet. So we were there in the first meet and also in the second meet. And also congratulations for starting the Chennai chapter of Hisi. So I'm a microbiologist. I finished my MD and DNB in microbiology. And Madam Uma ma'am was my examiner in PG. So thank you, ma'am, for that. Yes. So it's my privilege to be in front of such senior dignitaries and my madam. So my topic is a little different from what I've been talking till now. So at BD, I worked for almost 9 years as a microbiologist and then post that joined BD as a medical affairs manager. So I take care of the full South, the medical affairs for the full South in BD. So today's topic is on use of middleware softwares for data management and automated instruments in microbiology. This topic, I thought because I have been using it while I was practicing. So this helps us to use the infection control for preparing antibiograms, for understanding the epidemiology of the organism which is present, for understanding how much of, what samples are coming from different patients. So this is a middleware, this is a tool which can be used by microbiologists for so many different things. And it is a major part when we go and present in the hospital infection control committees. That's what I'll be touching today. So today's agenda, I'll be talking about what is the middleware, a general talk about it, what is it, what it means and how it helps. What is the use of it in automated instruments? BD, how we are able to support in giving a middleware, and also how it will be helpful in a microbiological laboratory. So every microbiology lab has its own issues with ever increasing challenges, higher workloads. We have stricter compliance measures. We have accreditation needs with more and more hospitals going in for NABL, NABH, JCI and whatnot. We have to maintain quality. We have to give fast results to the clinicians and also to reduce the cost. So in all this, we need to do along with our reporting of microbiology and being a part of the infection control. So this tool of middleware, which is available most of the companies, with us also is available, plays a very major role to reduce or to help us to give out data, to give out results, to plot graphs, to make graphs so that we can present it across in the infection control committee meeting. So it's an integrated middleware software which helps to achieve all these in a competitive world. So, and one more advantage is it gets integrated to the LIS of the hospital. So main advantage, the information can flow from the instrument to the middleware and into the LIS so that we can release reports easily, as well as the information of the hospital, that is the laboratory, from the HIS or from the LIS can flow into the middleware so that we get all data about the patient from the hospital itself. So it's an integrating tool, or it's a middleman between the hospital information system or the LIS, as well as the instrument which is there in the hospital. So as the name tells, it sits in the middle. It's somewhere in between, and it controls the whole ecotecture or the ecostructure of the hospital and the laboratory. So it helps to maintain the different instruments of an individual company in the laboratory, as well as it will be able to get information. It's a bidirectional one. So get information from the laboratory or from the HIS of the hospital so that we'll be able to give meaningful data to the clinicians, as well as meaningful data to the different committees and as well as to the accrediting organization. So middleware helps laboratories better and more easily compile and give data which is required by the accreditation programs. It also helps laboratories adhere to the internationally recognized best practice standards. So what all graphs which are shown till now, or what graphs I'll be showing in, can all be automatically generated in the middleware. So it reduces our time as a microbiologist and also helps us to give meaningful data to the infection control committees whenever we go and present. So they can not only give data, but they can do many variety of functions. One is providing more highly customized rules for real-time analysis than that is available in LIS. LIS has certain limitations. So they can do only certain things based on whatever the hospital or the laboratory requires. But a middleware can do so many more things which a microbiologist desires for or wants for. So that's an important, because it's a separate software. It's not a lab developed or a hospital developed software. So it's a software developed from the companies. So they are able to generate which is required for many, because based on whatever requirements or based on whatever surveys come from different hospitals, they'll be able to give the more number of data and more number of algorithms can be developed in it. Next is performing auto verification of laboratory results that meet the standards of auto verification criteria and flagging results for review that don't meet any of the criteria. So you can give certain criteria, certain alert rules, certain rules which say you can release a report similar to auto verification in hematology or in biochemistry. We can still set up rules so that we can release, suppose a no growth in blood culture can be released at 48 hours, at 72 hours, or at 5 days as required. So even without the intervention of a microbiologist, if you're able to train the system, give algorithms, we can release a report. Suppose a blood culture has come around 3 a.m. in the morning. After 48 hours, 3 a.m. in the morning, a report can be released even without a microbiologist sitting in the hospital or in the laboratory. That is possible with use of middleware. So next is performing holding and flagging laboratories. Suppose there is any issue, any growth or any positive indication in a blood culture, or the culture in suppose an automated instrument of IDST flags positive, or it has identified an organism, it will hold the result till the microbiologist comes, sees it and say if it is okay, then he or she can review it and release to the clinician. So in this way, it reduces the time for the clinician so that they can get the results at the earliest, and early in the morning when they come for rounds, they'll be able to have results. Especially blood culture reports is what doctors usually see for. Suppose they have a 48-hour report in their hand by the time they come at around 8 o'clock or 9 o'clock in the morning. It always helps them to start, stop, escalate, de-escalate an antibiotic or reduce the number of antibiotics given to the patient. The next is better display of data for quality control, which is approved and as per quality assurance analytics, which is there in most of the accreditation facilities. It is NABH, JCI, NABL. So we can give data which is required as per their standard or whatever is required, because it is not only for a single hospital or lab, it is all over. Not only for India, it is all over the world. So this middleware are customized, which is required based on requirement of JCI or NABL or NABH, whatever the accreditation body is. So they will be able to give a microbiologist the edge, so they'll be able to give data or produce data which is required as per the standards of the accreditation bodies. And last but not the least, directing samples in robotic automation. Suppose we are able to develop automation, they can direct which sample to go to which instrument, and then finally that sample can go to the storage area and get stored. So this automation and this storage can be done using the middlewares. So this is where it sits. LIS, we have the middleware in between, and we have the blood culture system. It can be any number of blood cultures which is there in the hospital. One can be the lab, one can be the ICU, one can be in the critical area. Wherever it is, it can all be integrated. One is IDSC instrument. It can be Phoenix, Vitec, whatever it is. It can be 1, 2, 3, whatever it is, or it can be any of the other systems. If you see the list, which is there, this is from BD. All the instruments which is here can all be tagged to a single middleware, which is initially it is a system based, but nowadays we are doing cloud based, so that all information can be held. Even a doctor who is sitting at home can still view the results of the laboratory and then release if at all he or she is not well, or if he or she is the only microbiologist in the hospital, they can still review the report sitting at home if it is an emergency report. That is still possible, and that is how it is coming up. So what does this middleware help in? Improve the microbiological testing process, reduces the TAT time, enhance the quality of the results which is coming out, as well as conduct statistical and epidemiological surveys. So all the information, because it has a higher storage capacity, whatever instrument storage capacity is less, or the LIS or the HIS, unless you have a cloud base, the storage capacity is less. Suppose you want to store a patient's information for almost 6 months, 8 months, 1 year, 2 years. It is always very difficult. You need to have hard copy of the patient's reports. But these instruments, because they have a higher capacity or they are cloud-based, we can store data for a longer period of time. It is like your emergency medical records, EMR, which is there. We'll be able to customize it so that we can store more amount of data in this and retrieve the data as and when required. Suppose a patient has come 1 year back, we can retrieve data, which organism has come. We can even make it pop up when required, so that we'll be able to check the sensitivity if the same organism was there. Suppose salmonella typhi was there 6 months back. Again, we are seeing the same organism. We can easily cross-check, and then if it is there, we can immediately call the clinician, ask them for a blood culture or stool culture, whichever is there. So that is the usability of a middleware which is available. It also, and as I told you, it can be interfaced with so many other instruments which is there in an individual company. Suppose BD is there, we have middleware called Epicenter. We can integrate Bactec, Midget, Phoenix, Innova, Brooker, and the LI system. So all this can be integrated into a single system. So I'll not take too much time into this, but these are the different things which we want: integration, analysis, communication, as well as monitoring. And a middleware software will do all this for a microbiologist. We can give expertise roles. We can customize the role which is required. We can give alert roles. We can say the instrument when to flag, when not to flag, when to inform, or when to send an alert message. There are certain facilities where they can send SMSs to the clinicians about the reports, like biochemistry reports. Similarly, we can customize the middleware so that it will send to the LIS. LIS can send the report to the doctors immediately. And we can report and also use for epidemiological testing. It can give proactive results, proactive alerts, multi-user access. Suppose, there are two microbiologists, both can see. Or suppose a microbiologist is sitting here, he wants to see a satellite lab, which is there, which is a lab where they have a Bactec effects, a blood culture system in a different lab. Sitting in one area, he can see what is going on there. Next, or a satellite lab, which is there, and then key in, because if you have only technician there, the report will be released from one laboratory. The same report which is there in a satellite lab can be released from this microbiologist sitting in another laboratory, which is another key which can be done using a middleware. So it helps to monitor real time from any location. So now with becoming cloud-based, any location the doctor is sitting, he can still see, and then if at all required, release a report on demand or on request. So anywhere, anytime access of instrument status, test details, how many tests have run, how many blood cultures have run, what is the time to positivity of different blood cultures which is there, what the time taken for the identification if in an IDSC system, what is the time it takes for the ID to be released, what is the time it takes for the sensitivity to come out. All this can be monitored because of the middleware which is available. Next thing is it can use as a single interface where you can, whatever is not available in the LIS, the middleware can support, and then we can release the reports, or we can give more information to the hospital, more information for microbiologists to go and speak, especially when you go and ask for budget, or you have to go and discuss regarding certain issues to the management. It will give us data over 6 months, data over 9 months, data over 1 year. We can use this data and then go and speak to the doctor. What is the MDRO rate for last 6 months, MDRO rate for last 9 months or 1 year, or the number of blood positives just come in last 6 months, 9 months, 1 year. All this can be got in a click, in a single click, and then we can go and present. And then based on that, we can ask for requirements or any infection control practices to be changed. All this can be done using this. Or if there is enough non-fermental like Acinetobacter, or there's an outbreak, similar organism, similar sensitive pattern is there in ICU. All this can be tracked using the middleware, which is available. So it helps to integrate data from multiple platforms, as well as if you're doing a manual test, those data also can be keyed into it so that you'll be able to get a comprehensive data to be presented to the management or to the infection control committee. So for a microbiologist, how it helps to monitor epidemiology. It helps to not only collecting data, but present it in a way which is palatable to the management, to the clinicians, to whomever it is. So it helps us to give it in graphical format, in statistical format, and also epidemiologically to make it so that it is easier for us to present whenever required. So also providing data in its raw form is not enough. So we need to give it in a proper palatable form. So these tools, this middleware plays a major role in it. What are the advantages? Information is clearly displayed. It is integrated in continuous education. It helps to educate our staff, or if you want to tell what is the exact rate of MDROs, what is the exact rate of staphylococcus or MRSAs coming in the hospital, we can use it and then educate a clinician. There is a chance of outbreak in this ward or in this ICU. Please take care. That also can be done. Automate quality assurance, and also we can get access to the individual patient history. So just a few snapshots of how the middleware looks. So here, if you can see, we can see large number of data. This is patient centric. You can use patient specimen centric. It can be used, or you can isolate centric. You can use. So there are different options based on which you can enter and then get the data, or you can generate graphs based on whatever is required. So this is how individual messages come out. If it is an MRSA, if it is an ESBL, if it is staph aureus, what it is, all this can be tracked based on using the middleware. Same way, based on the antibiotics also we can track. If it is an ESBL, if it is a CRE, what it is, and which antibiotic is sensitive, what is the previous time, what was sensitivity, now what it is. So all this can be done. So this is again expert rules. Based on whatever rules are there, based on CLSI or UCAST, we can see what is the alert rules which is there, or we can even customize the rules which is required so that we'll be able to feed into the system so that they accordingly will release a report. So the doctor, it comes out in a way that it is easier for the microbiologist to release a report directly to the clinician. I'll just take a little less time because of the paucity of time. So again, Epicenter EpiCare, where it is clinical application rules editor. So we can customize our rules, give our rules, and say this antibiotic to be released, or we want cascade reporting, only these antibiotics to be released in the report. All this can be done using a middleware. So it helps us to do research also. If any doctors interested in research, data generation, retrospective data generation, getting data, giving it in different formats, in a graph, pie graph, bar graph, whatever is that is possible using the middleware. So if you see, these are the different reports which can be done. Each is a click open. You can take it as specimen-wise, patient-wise, service-wise. If it is a HAI, whatever is there, organism incidence, whatever is there can be released taken from this. This is how the graphs come. So once we get 1 month, 2 months, 6 months, 9 months, whatever data you want, you can take. If you want E. coli separately, Klebsiella separately, you can individually take it out from the instrument. So this is how the incidence comes up. So this is based on the location wise, you can take, if it is ICU, total number of organisms, what is the percentage of resistance which is there. So all can be whatever based on whatever is required, we'll be able to do it. So this is MRSA incidence, we can still get what is the resistance level incidence. So all these can be generated, transferred to the pen drive, and then taken and then presented in the HICC committees. So this is about blood volume monitoring. Another advantage of using the middleware is we want to know which ward is sending less amount of blood for a blood culture. It is still possible. It will tell us, suppose you're getting 4 ml, 5 ml, or 6 ml from an individual ward or an ICU, or suppose it is a reference laboratory. if you are able to get from a single collection center, they say only 5 ml is sending, we can generate the report and then inform them that only so much amount of blood is coming from your area. Please send adequate amount of blood. So retrospectively or analysis also can be done, and then we can inform what is the requirement from the patient. Is again a requirement from NABL and JCA where they want us to give the blood volume monitoring. So with multiple specimens also you can say, you can generate graphs. Recovery rate, we can see, what is the microbacterium species, what is the percentage is available, MTB or, NTMs, what is the percentage you can generate, or, you can take time to detection or time to positivity, we can still generate with this. It also shows the growth patterns, the time taken for once a growth control is positive, how long it takes for sensitivity or resistance to be identified. All this can be generated in this. And we can even give plot graphs like this so that we'll be able to display it to the HSC committee or to any of the NABL or NABH or JCI. It helps, it is multi-user who can, use it. It can be the pharmacist who is using it, physician who can get access to it, microbiologist who can get access to it, the ID physician can get access to it, but the access can be limited based on whatever is required for them. The full access is with the microbiology lab, but whatever is required for different sections of the clinicians, it can still be done. So sorry, I was a little fast with this because of paucity of time. So thanks for the opportunity given. So any questions, I'm ready.
Thank you. And we are, I think, waiting for the last session. We will just have 3 questions that we have. I request Dr. Shubha to moderate this session. I request Dr. Tyagarajan Ravinder, Dr. Vidya, and Dr. Suresh to take their places on the dais.
Welcome, panelists. We have people who are like pillars in their own sectors. Our ID physicians for adult, Dr. Suresh sir is there, Tyagarajan sir. In the government setup, he's doing a huge job with respect to infection control and management. And Dr. Vidya ma'am with respect to pediatrics ID. So the first foremost, if you have any questions from the audience, we'll go by the questions from the audience. If there's none, we'll go into the question directly. Any questions from the audience? No, okay. This is what we felt. A few of us just came up with some questions which we want answers from the experts. Suresh sir, there is we have a huge knowledge sharing from, the lot of guidelines about adult vaccinations. But what do you think is that practicality versus the guidelines? Is that all happening? Are people open to it? And, that's something which we want to learn from you.
Before answering your questions, the questions what they discussed during the time regarding the surveillance of HA, what they do, particularly Dr. Todi wanted to know how you are calculating the VAP. That's more important compared to the vaccinations for this crowd. That's what I think. So the VAP, the only place in the hospitals in Chennai, my nurse should say why the patient is not having VAP and the culture is growing a bacteria. We need to do 48 hours, or less than 48 hours, the intubation is over. Less than 48 hours, we ignore it. More than 48 hours, if the patient comes to me, my nurse should say why this patient is not having a VAP. So they need to put minimum CPA score. My nurses are trained, my ICNs are trained. They need to tell what is the CPA score for this patient, not only for the VAP, for UTA also. When a patient is 48 hours, why they ignore the bacteria in the urine. Similarly, for the bloodstream, why the patient is ignored for the bloodstream infection, they need to justify. That is more important. Second thing, hand hygiene, you are telling about 95%, 95%. When you use another person, simple thing that this hospital has got a very good physician assistance hospital there. I use a lot of training under me there. I just put them, do the hand hygiene, train them to do hand hygiene and send them for hand hygiene. The ICN nurse shows 90%, my PA does the audit 16%, 20%. So there's a reality there. So if you do some other person, definitely it changes. Clearly, Dr. Anusha also mentioned about the effect, what is happening there. So if you send somebody, you can easily figure it out there. As far as adult vaccination is concerned, it's the easiest thing. So what is required for adult vaccination? The only one vaccine, influenza vaccine take every year. If you're above the age of 50 or if you got some comorbid, take pneumococcal vaccinations. Of late, tomorrow I got a session there. Nowadays, the herpes zoster is also coming up. you need to take 3 vaccines as an adult. Pneumococcal vaccinations for people above the age of 50, previously 65, now 50, and people with comorbid condition need to take pneumococcal vaccinations. Everybody influenza. There is no upper age limit. 6 months above, everybody is supposed to take flu vaccines. And herpes zoster, again above the age of 50, we need to take. So these are the vaccines for adults. This is very easy to implement. We got a center running from 2012. We daily administer 25 to 30 vaccines a day, even before COVID about. The adult vaccination centers working our center. Only it should be close to the people who are prescribing. For example, I am prescribing means the vaccine should be given in the same center. If I write the prescription, my vaccine center is away, people won't take it. And second thing, what practically we can do, master health checkup, we need to mention one column for vaccine advice. The advice is free, but vaccine is not free in the master health checkup. So mention about the vaccine at the end of the master health checkup, you diagnose this patient has got diabetes, this patient has got coronary disease, CKD or something in the end of master health checkup. You just mention on vaccine counselor, he suggests advice. These are all the vaccines required based upon the new diagnosis what you made or whatever existing diagnosis is made. This is the vaccine you're supposed to take. So to implement the vaccinations, we need to have some advices. As far as healthcare worker is concerned, it's very easy. Then again, we need to take flu shot for people working. Everybody in the hospital, we need to take flu shot. And people working in food and beverage, they're supposed to take salmonella. Previously, we used to give once in 3 years, but nowadays we are giving one shot vaccination has come. And similarly, hepatitis A is mandatory, but again, people check hepatitis A, IgG, serology. Serology positive is not required. And people working in housekeeping, as well as people working in engineering department, 1 dose of TT. Nowadays, we're not giving TT, we're giving TD. So these are all the vaccination that is easy to implement. And hepatitis B, everybody is mandatory. So there's no role for hepatitis B. So these are all the vaccinations we can give.
So we have learned a lot of this basic about adult vaccination is from your team. So, I mean, are there any data from the team itself, or like from 2012 till date that, you've seen the adult vaccination, in your clinic run? Is there a trend of increase over this period that you have seen?
What the paper we presented, actually, we are going to present in the September month in DICPIC, we are presenting a paper. What we are presenting is between 2012 to 2020, before the COVID, we put the 3 years, 2015 to 2020, pre-COVID era, during the COVID era, and now post-COVID era. After 2022, what happened in pre-COVID era, the vaccination was reasonably good. I told every year we are giving 12,000 to 15,000 vaccinations. During COVID time, all the vaccination has gone till the COVID, because COVID is not given in our vaccination center. There's a separate center. So my vaccination center, the COVID numbers has come down. During the time, adult vaccination has come down. After the COVID has gone from 2022 onwards, it's slightly picking up. One of my interns did the project and the paper is, yesterday we heard the news, the paper is accepted for ICPIC presentations. So I think they're going to present this paper coming September. So pre-COVID, almost 12,000 to 15,000 vaccinations per day, per year we are giving it. And during COVID time, it dropped to 4,000 to 5,000 COVID era. After COVID, again, it started picking up to almost 8,000 to 9,000. That's what the number shows. I need to check again the data. So this is the data we are having right now.
Thank you, sir. That's quite informative. And one last question, it just came up with the points that you shared. Now the CPI scoring, can we by any chance institution wise, can we start implementing to look at VAP? I mean, I know that's the clinical scoring. And we do also realize that while we do the VAE, what we do analysis for our high setup, I mean, there's like, we hardly get any VAP that's understood, even for that matter, VAE. That is because it's not fitting into the definition of PEEP and FiO2, and it's not getting it. Is it like CDC has brought in that so that they don't want to pick up any VAE for insurance reasons? This is what we've been talking. See, these are the practicalities that we need to understand across the same forum. And I mean, can we start doing, say, clinical scoring just to improvise things? Because as one of our other esteemed persons said that we might not have to, give antibiotics for that matter at all. So we look in the long run on clinical efficacy of how things are happening at each of our setup. So if we can really go by clinical scoring and use that for our internal indicators, we don't have to present to anybody. So we don't have to answer others, but can we do it for ourselves to see how things are happening at our setup?
CPA score is easy to do it, except one parameter called radiological investigation. That only the nurses are struggling with me. Otherwise, other parameters are easy to do. It has got very good negative predictive value. It helps to rule out VAP, but the sensitivity and specificity is not great. Actually, the clinician need to overlook. So at least the nurses know whether to suspect VAP, whether to ignore the organism. So what they used to do, put a chart, all the organisms grown 48 hours later, they'll come and discuss with me. This patient has got 48 hours, right? This is a WAP score I come. I have not put the X-ray chest, right? No, right. Off late, they start reading the X-rays also. Off late, lot of artificial intelligence helping out to put what is a pneumonia patch is there or not. That also it's helping out. So the nurses also start using that one that's possible. So it helps them to rule out infections. The possibility of infections can be ruled out with CPA score. But CPA score is practically possible with nurses. If we train them properly, they can able to do it. And we can supervise, we can monitor, we can help out. But the technical definitions of whatever given by whatever given by the authorities is slightly difficult to implement. This is a practical tool for nurses to can do. They can able to justify whether it's WAP or not WAP.
Thank you, sir. Any other questions in this? Okay. Thank you so much, sir. Can yeah. Right.
Many a times clinical decisions are taken on something which is not illegal. In some ways, it is very specific to whether they are fitting in or not.
Not fitting. Correct, sir. Right.
That could be a major issue using a clinical definition process.
Correct, sir. Right. Yeah. That's what's after a point like, okay, I know we are doing it to monitor, but then we also have to do something to do something better from what's happening. So when we don't have any numbers because of this kind of monitoring on VAE, again, we are really not sure on that part. Are we contributing enough? So that's the concern. That's all.
What Dr. Madai is saying about it is very right. So one of use that data to decrease down antibiotics.
Yeah.
But
Okay.
in that case, we have to depend on the clinical data rather than the severity.
Thank you, sir. Can we have Dr. Tyagarajan, sir, just now, I mean, we've been talking many things on infection control, but when it comes to resources, which is like a, big setback at government setup, of course, I think we might have to reach out more to implement things. But what do you think might be the setbacks or the opportunities that at government setup, it can be improvised? So your inputs.
First of all, senior delegates and friends, good evening to all. Thanks for the opportunity given. In government setting, the main challenge is the number of patients admitted and the crowd. But now logistics are much better from the government sector as well as NHM fundings are there. And moreover, now NABH is being implemented in most of the government tertiary care centers as well as secondary level. So quality has improved a lot from the past era. Still, there are challenges to be faced. Main thing is the implementation of various infection control practices, and of course, the monitoring of this implementation. So now there are trained infection control nurses headed by a nursing matron. So their team goes around and sees how these things are implemented. And also, as a microbiologist, myself as well as my team, we venture into various places, do surprise rounds, and find out the compliance of various aspects of infection control practices, including the hand hygiene. As theoretically speaking, it is again showing 82 or 85%, but I also very apprehensive about it. Practically speaking, we do know what is the reality of hand hygiene compliance, particularly after the hours, after the day shift is over. But and one more thing is the visitors, they're also touching the kith and kin, so hand hygiene gets defeated there. So some policy has to be there to implement strict hygiene. In some of the intensive care units, it is possible where even their patient relative has to wear some minimal personal protective equipment as well as do a hand hygiene and then only go inside and he can touch his relatives. But in general wards, it is not at all possible. So these are the main challenges, and we overcome this by mainly the training programs for various sectors, groups of people right from the CRRAs, postgraduates, junior doctors, senior doctors. We have programs, and for the nursing staff, exclusive programs we conduct. And particularly in government sector, in my department, we concentrate
as a team, along with the medicine and surgery departments in the HICC, we concentrate more on training the hospital workers who form the major workforce for implementing infection control, as well as the major component in infection control is biomedical waste management. If done effectively, almost 90% of infection control job is over. That forms the source of infection for most of the infections related to healthcare associated infections. So we mainly concentrate training the hospital basic workers, and this training compulsory or mandatorily, we do it in the regional language, in which way they understand and motivate them, encourage them to do the infection control practice, as well as the disposal or management of biomedical waste. So with that, we overcome these challenges. And as a microbiologist, we implement the monitoring in various high priority areas like operation theaters, then various intensive care units, including the neonatal intensive care unit, which is the major challenge. And of course, the CSSD also. And particularly for my medical college, where I'm coming from is Kilpauk Medical College, Chennai. The special unit is burns. We concentrate much on the burns care, and it is a center of excellence. Burns, initially there is not much of infection, but after the first week, patient is recovering from his own burns and whatever lung injury or muscular injury he has. But when he is doing well, he suddenly succumbs to the sepsis. So that is a major challenge in my hospital. Again, meticulous infection control practices helps to overcome this. And of course, to top the list is the antibiotic stewardship. Along with the support of physicians, surgeons, and various other paramedicals, we concentrate on antibiotic stewardship. And of course, we see some results also. So these are major challenges, and we overcome by training and creating awareness. Thank you, ma'am.
Totally agree, sir. Actually, training can do wonders irrespective of the setup, whether it's private or government. I totally agree with you. If there are resources also, if people are not trained, there's nothing going to happen. Thanks so much, sir. The insightful. I mean, it actually inspires many of them. Thanks a lot. Thank you. Yeah, to Dr. Vidya, ma'am. It's one our favorite question, because we've always been thinking about this. We have challenges in, implementing on surgical antimicrobial prophylaxis with respect to pediatric surgeries. I mean, there's not much. I mean, I don't know. You will be able to help us on the various guidelines that are available for this. Otherwise, for adult, we follow the HSP. If we can put the same thing or translate. So that's something we are always stuck.
So I think pediatrics is often a most neglected part of medicine is what I look at. Most of the, increasingly we are doing a lot of complex procedures in children, and we are catering to a wide variety of children with, say, immunodeficiency, complex congenital heart disease, chronic lung diseases, children, and even extreme prematurity. So I was talking about NICU. Neonates whom we didn't expect them to survive and reach, say, even infancy. Increasingly, we are seeing that kind of population, and we're doing a lot of interventions. Whether we have data on dealing with such complex hosts, again, I would just say that it's emerging, especially we have some data from the West. From India, there's very limited data. But probably that's one area where we should be starting to look at multicentric studies or multicentric collaborations to try and develop what Dr. Uma ma'am was telling about, generating our own guidelines, generating our own data. Coming to directly answering your question, I think the principles of preventing surgical site infections are very much similar in children when compared to what you would do in adults. But probably the areas where we would differ a little bit are in probably the way you dose your antibiotics. And again, most of these, children, again, depending on the host, if they are immunodeficient, if they are particularly colonized, if they have an underlying predisposition like cystic fibrosis, pathogen-specific modification to the surgical antimicrobial prophylaxis is something that we would be looking at. But otherwise, the principles seem to hold the same. I've taken up this pediatric, HIC very recently from Dr. Suresh. So he would also be able to add more to it. But I think the guidelines are mostly from US or from Europe, and they are mostly, if you Google in the net, you would get a center-specific guideline. So I think we also have our own center-specific guideline,
which would be very much different from what you would see, say, using first generation cephalosporins for GI surgeries and all that might not be what we practice. We try to incorporate our own epidemiology of ESBL gram negatives and enrobes and all those things. So I think it's important to have your own data and generate your own data, get multiple centers together and publish local guidelines.
Thank you so much, ma'am. That's insightful.
I have a comment to make on that. See, in surgical prophylaxis, actually, what we are targeting is not ESBLs or MDROs or so. What we are targeting is the
Skin
local
flora.
flora of that particular place.
Sorry, sir, I just mentioned specifically for bowel surgeries.
Yeah, that's what,
Yes,
yeah.
sir.
For bowel surgery, I can understand, but
Yeah.
that too, one has to be skeptical.
Yes.
Whether the child has been exposed, for how long has the child been exposed to hospitalization or to a hospital atmosphere?
Yes.
That is something where we are to antimicrobials for that matter in the community. So that sort of a thing, I think we have to rationalize. It is not a very easy task to rationalize all the things. But still, if we really want to go ahead, this is something where, we had very good run with cefazolin
Mm.
as a single antimicrobial in cardiothoracic surgery. Very good run with it. But, someday some person tells, okay, add on teicoplanin into it. So without any thing,
Yeah.
why cefazolin was being given and why teicoplanin is being added?
I think I agree with you on that. See, if you even look into pediatric specific data on complex cardiac surgeries from US, repeatedly there is an issue with people using BLBLIs with Targocid and continuing it for 48 hours and beyond.
Right.
So most often, the surgeon would tell me that the chest is open and I would like to continue my hand. The challenges we face in pediatrics are very similar to what you would face in the adult world of not stopping antibiotics, trying to broaden spectrum, the more complex the interventions are. So I think, as you rightly said, most of the times, if it's the skin flora, we try and restrict it to cefazolin. Sometimes with complexities of the case involved, even if it's a broader, we try to narrow down the duration. Stewardship is probably more important than, I think, trying to be upfront with sort of working in collaboration with them.
So that is, thank you for that, but you got a very positive point that I haven't come across a pediatrician who is not sincere. I am so sorry with other people, but that is what it is. They are very, in fact, at the cost of their own lives, they would try to give whatever they have to the child. So that's a very big positive thing with pediatrician and neonatologists. Sir, for burns, I have one thing which we all faced and keep on facing is differentiation. See, there are two aspects to it. One is what people term as sepsis. So if we start analyzing anything which is by release of certain chemical mediators of inflammation, well, that has occurred quite a number of times after dressings, just a few hours after dressings. And there's a massive release. And it's very difficult to differentiate between SIRS-like picture, or you can call it by any other name. So SIRS by like picture or a true sepsis. Now, second thing is whether this organism which was taken up is a colonizer or is it actually the cause? Most of the burn area is a large area, large surface area, which gets very well colonized, and organisms have been shown to move from periphery into the center also. So there is a big challenge there with burns. Many people have tried, we also tried sometimes about taking gram per grams, how many
Tissue,
of the
organisms
tissue.
per gram of tissue.
It doesn't help out.
Yes, sir. The challenge is taking the sample from a burns patient. If superficially taken, only the colonizer grows. So after the debridement, the tissue bits from the deeper areas need to be taken. And mostly we rely on the blood cultures.
Even blood culture, sir.
One,
Because it's very difficult to find lines.
that's true.
you know.
That's challenge in the critical injury patients.
Fortunately, he's heading the major public sector hospital of the burns. I'm looking after the major private care sector of the burns. That is only dedicated center of the burns in one of the centers I'm working. So we also come across whatever points you come across. But fortunately, I got a very good plastic surgeons. In fact, the plastic surgeon says, I don't want antibiotics. This is a call. And I said, the wound is looking good. So he says, even I said, are you okay? He said, I'm very okay to stop the antibiotics. Despite 40%, 50%, even 60% burns, day 3 to day 5, unless the patient has got hypotensions or organ dysfunctions, he won't start antibiotic. As far as regarding the pediatrics is concerned, before I was heading there, in 2010 itself, the pediatric unit, that's the only unit in Chennai I know, they stop antibiotics within that time 48 hours is the guidelines. They stop 48 hours almost 60 to 65% of the time. And we empower a nurse also. The nurse go and ask the surgeon if he continues the antibiotic, can he take it as a surgical site infections? The surgeon agreed, stopped on 30% of occasions. Just one question stopped it. So in fact, this paper we published in HICAC that time in 2010, and we won the grant also for the thing. So almost 1,000 hot cases, 60% is an adherence, my cardiothoracic surgeon. I empowered my nurse, asked the questions. If he shoots more than 48 hours, can I take it as a surgical site infection? He said no. Then you stop antibiotics. They stopped antibiotic almost 35% occasions. Pediatrics, the concern is urology. That's a bit difficult because most of the time they do a lot of complicated urological anatomies. They want to correct it. And most of the time the urine is growing some bacteria. Usually the surgeon is back and they're going to put the Foley catheter in place for 5 to 7 days. That's only the challenge. Even though there is no cutting the skin, but going through the procedure, they're doing it. So we can't technically call it a surgical site, but they do through the urological intervention. That's a challenge. Already patient is colonized with bacteria. And they're going to place a catheter also. They're going to do the interventions also. There only the challenge is there. Otherwise, usually cardiothoracic surgeon, if you explain it, they'll agree it and they'll stop the antibiotics. And gastro also, right now a lot of guidelines are available. The challenge in pediatrics is in neurology is a bit difficult.
So we've had an excellent session today. Thank you to all the resource persons and to the, all of the people of the Hisi chapter who helped me out to do this. And a special mention to the team in MMM, both my department, the IT department, and the biomedical department, engineering department, the FNB, and to the PIMS team who came all the way from Pondicherry for this. And to each of you to have taken, we have had 344 people who have actually logged into the program. So that was a phenomenal thing. Thank you all for being such an integral part of this. We will, next time onwards, we will stick to a little shorter sessions because everybody is busy. Thank you so much for your time today, though. We really appreciate it from our hearts. Thank you. It's all together. It's a team. Kripa. It's a team, sir. It's a team. And thank you for giving so much time to us. We're grateful for it. Thank you.